Hi, Dr. Ahmad. Good morning. Morning, boss.
The participant not in yet lah.
The participant is in another, is in Zoom, but this is only for panelists. Dr. Ahmad.
Oh, okay lah.
Yeah. Just
Morning Najib and Zainal.
Morning, Samad. Hi.
Hey, morning, Ahmad. How many participants are there?
Jeffrey, you want to answer the question by Najib? About 200.
Hello, hi, good morning. A very warm welcome to the UMC Urological webinar. Busting Common Urological Myth. I am Jeffrey Lim, the chairperson for today's events. And in a world filled with information, it is crucial to differentiate fact from fiction, especially in urology. Just a reminder, as we embark on this enlightening journey, I suggest that each of you can actively participate and post your questions in the chat box, and our panel of experts, where we carefully selected from various corners of our country, will unravel the misconception and share the insights that will enrich your understanding of urology. Without further delay, I would like to introduce you to our Head of Unit of Urological UMC, Dr. Ahmad Najran, for prologue. Thank you, Dr. Ahmad. The floor is yours.
Yeah, hi, good morning, everyone. So just want to say, thanks everyone for taking the time off on a Saturday morning to come and get this educational event. Okay, so as you know, the theme is to busting common urological myths. So we have prepared, a wide range of topics that we hope that will actually get you so that you know the true information regarding these things. Because since COVID, we have a lot of information online, but sometimes we don't know how valid is information. So I can guarantee that everything stated here is 100% valid. So as Dr. Jeffrey mentioned, we prepared quite a range of speakers from both our government, private, as well as private hospitals in West Malaysia. So it should be an informative session, and all of them I guarantee are not just very informative, but also they are friendly if you want to see them. Okay, and I have to thank our sponsors from the pharmaceutical industry. You can see at the side there. Thank you very much, because without the support, this thing will not be a success. And I cannot, last but not least, have to mention thanks to my team led by Dr. Jeffrey, Dr. Shuhada, for working, who have worked very hard to hopefully make this event a success. I said last, but more importantly, to make this webinar a success, what we need is all you participants. Okay, because without you guys, this will not be a success. And we really hope that you will engage with our speakers and feel free to ask any questions, so that you can feel, as you say, you can bust all the myths that you are unsure about, and every one of us can learn and be wiser after this webinar. Okay, without wasting more time, I would like to say that to officially start this webinar. Okay, thank you.
Thank you, Dr. Ahmad, for the prologue. Thank you so much. So without further ado, I think we should start our webinar for today. I will pass the screen to our moderator, Dr. Shuhada. Dr. Shuhada, the screen is yours.
All right, good morning, everybody. Assalamualaikum. I'm Dr. Shuhada from Urology UMMC. So I'll be the moderator for plenary 1 and 2 today, along with Dr. Vishal for plenary 3. So it will our great honor to invite our first speaker for today with a topic of, could my prostate enlargement be a sign of prostate cancer? So our first speaker is Dr. Zainal Abidin, which is a consultant urologist and robotic surgeon from Hospital Al Sultan Abdullah UITM Puncak Alam. He completed his fellowship from Queen Elizabeth University Hospital Glasgow for robotic pelvic uro-oncology. Currently, he's a consulting editor for British Journal of Urology International Compass. Without further ado, we'd like to invite Dr. Zainal for his lecture. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. A very good morning to everybody who is dialing in to this webinar today. Firstly, I would like to record my congratulations to the urology team at University of Malaya for their initiative to organize a set of webinars to enhance urological awareness to the public, and also a specific day for clinicians. My name is Zainal Adwin. I am the head of urology at the Department of Surgery, University Technology Mara. I've been given the opportunity today to speak to you about prostatic enlargement and how it is related to prostate cancer. Today's talk will be centered around the prostate. I will give a little bit about basic information about the prostate, moving on to two common diseases related to the prostate. The first one being benign prostatic enlargement, and the second one being prostate cancer. It is very, very interesting that the prostate causes problems when you get older. So, ladies and gentlemen, the prostate is specific to the man. In development, there is an anatomical analog in the women, which are called skin glands, which share similar function as what the prostate does in the men. The prostate is shaped like a walnut. Its size is usually around the ranges of 20 to 40 centimeters cubed. The rate of growth of the prostate differs at different ages for the individual. However, most of the symptoms are related to an elderly or at an older age group. Size does not entirely dictate symptoms. You can get symptoms of prostate issues with a rather unenlarged gland. Anatomically, the prostate is located below the bladder and surrounds the first part of the urethra. The urethra is a tubing that carries urine from the bladder to the external environment. The prostate sits on the urogenital diaphragm, which is a very important collection of muscles that are related to the sphincter mechanism that controls passage of urine. The main function of the prostate is to produce seminal fluid, of which seminal fluid is mixed with semen and is ejaculated during sexual intercourse. Seminal fluid provides nutrition for the survival of sperm and also protects sperm from the environment that it is going to endure when it travels to be impregnated. Prostatic issues are more common in older men. It is very rare that you get issues with the prostate in people who are in their 20s. However, I've got to say that I am seeing a lot more younger patients with inflammation of the prostate, which is also known as prostatitis. This topic is a rather huge topic and best be left for another webinar, perhaps. The two big diseases associated with the prostate are benign prostatic enlargement and prostate cancer. When you talk about the prostate, you should be aware that there are a set of symptoms most often related to the prostate. The collection of symptoms are called lower urinary tract symptoms or LUTS. It is a set of symptoms characterized by urinary frequency, urinary urgency, or where there is a compelling desire to urinate, nocturia, or waking up in the middle of the night or after sleep to pass urine, weak stream, which there is poor flow of urine going out, sometimes associated with dribbling at the end, intermittency, because there is weak stream and you get a starting and stopping of urination in short bursts of time. Straining is defined as the need to increase your intra-abdominal pressure or strain to push urine out of the bladder, more commonly in the morning. And the next is incomplete emptying. It is when you pass urine, you will feel that there is a little bit more urine left inside the bladder. This is a very uncomfortable feeling, and oftentimes it can cause complications such as urinary tract infections, bladder stones as well. If you go to a general practitioner or a urologist to discuss your lower urinary tract symptoms, most of us will use the International Prostate Symptom Score. This score is an objective assessment of the symptoms, and it will give us a number that we can see and monitor progress with treatment being given. In terms of distinguishing between benign and malignant diseases, there is no way to differentiate based on symptoms alone. There is a need for more invasive methods such as blood taking, MRI screening to identify whether or not this prostate issue is cancerous or not. We move on to benign prostatic enlargement. Ultimately, benign depicts non-cancerous. However, it causes significant grief to the elderly gentleman. The exact cause remains unclear, and it is hormonal and age that plays a significant role. There is a balance between androgens and estrogens hormones in the man. As they grow older, this balance is disrupted, and what happens is that there is an increased stimulation of the prostate cells to proliferate or to increase in number, causing an increase in size and formation of nodules within the gland. And as you remember, the prostate surrounds the urethra, the tubing that carries urine. Hence, that it will be causing urinary obstruction. In terms of treatment, there are many options available. Medication and also surgical treatment as well. Recently, there is an increase in minimally invasive therapy for the treatment, and ultimately this has improved symptoms and also improved quality of life for most patients going for it. Next is prostate cancer. Prostate cancer is increasing in its incidence as a lot more nations are increasing their life expectancy. At the moment, it is around 5 to 6 cases per 100,000 population. 60% of prostate cancer is diagnosed in men aged 65 or older. The risk of getting prostate cancer for people under 50 is relatively low. However, more caution should be applied if there are significant genetic risks involved and if there is a history of familial prostate cancer. Its incidence locally is increasing because Malaysia is already an aging nation and is set forward to become a super aging nation by the year 2050. Similar to our counterparts in Asia, Japan, which has already reached super aging nation status in the year 1990s. In terms of racial predilection, prostate cancer most commonly affects the Chinese first, Indian second, and next Malay. Most prostate cancers grow slowly and may not require treatment. However, their behavior is rather heterogeneous. Each acts a different way. You can't predict their behavior. Some cancers are aggressive, spread quickly, and require urgent treatment, whilst some cases are rather indolent and slow and will not cause any significant harm in their lifetime. Based on this understanding of the disease, this has brought upon the concept of active surveillance as an arm of management for prostate cancer. Patients with lower grade cancer who are expected not to behave aggressively and might benefit or will be more at risk of complications from the treatment is suitable to be put under active surveillance. It is essentially a balancing act between the advantages of treatment and also complications associated with it. Prostate cancer, ladies and gentlemen, if it is low grade, localized, and treated accordingly, has a 98% survival rate which are really good numbers. If the cancer has spread, the survival is around 4 to 6 years. Some therapies are able to increase that, however, not super significantly. When you talk about prostate cancer or the risk of having prostate cancer, I would like to use two calculators. The first one will be the PCPT calculator, which is based on a large trial which looked at prostate cancer prevention, and they have derived data from that trial to create a calculator that will give you some numbers with regards to your risk of getting prostate cancer. The second one is based on a similar study called the SWAP, and they've also devised a calculator to help with identifying who is at a higher risk of prostate cancer. If you look at this first one, this is the calculator from the PCPT trial. There are parameters there which are race, age, your PSA or prostate-specific antigen, family history of prostate cancer, and your physical examination findings from the digital record exam, and whether or not you've had any biopsy done before. Let's give it a try. For a regular 70-year-old with a rather increased PSA and no family history or some family history of cancer with a normal digital record exam, and this patient has never had a biopsy before, first time coming, or yourself just trying to see whether your risk is where your risk is at. And you can see based on these parameters, the patient who is a 70-year-old gentleman with a PSA of 9, with a family history of prostate cancer, and has never been worked at before, this could be you, this could be one of the listeners tuning in to this webinar. You have a 16% chance of high-grade prostate cancer. You have a 27% chance of low-grade cancer. And if you decide to go for a biopsy, up to 50% risk of that biopsy will be negative. Having said that, you've got to understand that when it comes to biopsy for the prostate, to the conventional way, which is a transrectal ultrasound-guided biopsy of the prostate, around 4% of people will be getting complications from that biopsy. Hence the advent of more newer technology, such as the transperineal approach to biopsy of the prostate, which relatively carries a 0% risk of infection. However, do not use this calculator independently. It should be with guidance or counseling from your doctor. The next will be the SWOT calculator, which is for the individual who has not had a PSA done before. They also have a calculator if you have a PSA readily available, but we'll look at the non-PSA calculator. This employs family history, age group, and also urinary symptoms, identifying it akin to the IPSS questionnaire. So if you look at it, I'll just rather put simple, moderate lower urinary tract symptoms around the regular 65 to 70 age group. And you can see that based on the calculator, without a PSA, the risk of that individual getting prostate cancer is 10%. So ideally, 10% is the risk that you would not want to take. Hence, you would want to get a PSA done and furthermore identify your risk a bit more. So we're coming to the gist of the talk, or the main topic, which is big prostate, more risk of cancer. So I'm going to bring your attention to this paper published rather recently, which looks at association between size of the prostate and the incidence of prostate cancer. It is a meta-analysis. So a meta-analysis is a collection of papers which have the similar headline or topic, and it is statistically analyzed to identify whether the results are congruous or not. So this is the first report summarizing the literature on the clinical question of size and incidence of prostate cancer. From this paper, they looked at 30 studies which has the same headline, which is prostate cancer and prostate size, and 90% of them shows that prostate size actually may be protective of prostate cancer. So this should really encourage more investigations to explore the relationship between prostate volume and incidence and the aggressiveness of prostate cancer. Because as the prostate enlarges, different zones will enlarge, and you can identify the relation between prostatic zones and its relation to prostate cancer. Furthermore, this will allow us to identify who's at risk for prostate cancer and deliver treatment rapidly and more effectively. Whatever it is, ladies and gentlemen, when it comes to signs, symptoms may not really be in line with size. As I've mentioned earlier, the larger prostate doesn't mean that you will get worse symptoms. So if you have been diagnosed with a large prostate, I would sincerely ask that you get PSA screening as well. PSA is prostate-specific antigen. It is a blood test of which is done to identify people at a higher risk of prostate cancer. Its utility in screening is rather debatable. Many studies in America have gone against it, whilst in Europe, PSA screening has been included in their screening recommendations. We do not have a local screening policy when it comes to PSA. However, if you notice, there are many health facilities offering PSA as part of a package of tumor markers or cancer markers. More PSA screening is done, you can identify more cases of prostate cancer and its effects when you detect these prostate cancers earlier. However, you must remember that mortality from prostate cancer is related to access to care and care quality. And we are blessed in Malaysia that we have acceptable or rather above average access to healthcare, and the quality is of acceptable standards. In summary, the talk today, I would like to say that be aware of prostate cancer. The larger your gland, you might be perceptive. However, you should not sit in your laurels and not do anything about it. Get screened, get investigated, go see your doctor and identify your risk of cancer, get diagnosed early and treated effectively. I'm happy to take questions with regards to this topic or anything prostate cancer or urological related. I'm happy to be contacted by social media or email, and if you screen that QR code on your screen at the moment, or you will get to my contacts and can contact me for your questions. I hope that the other topics today are as beneficial or more maybe, and I hope that these webinars will increase urological awareness in the community, and there is a urologist for you. Thank you very much and have a good day.
All right, thank you, Dr. Zainal. So thank you, Dr. Zainal, for an enlightening and entertaining presentation for prostate enlargement. So I believe there's a few questions from the Q&A session. Just hold on, just give me a second. So there's a question here from Mr. Tamil Ghani. The question is, what is the cut-off age, upper limit for PSA screening in older men?
All right. Hi. Good morning, everyone. Thank you for listening to the first part of the talk. Zainal here. I am going to give some answers to these questions. And I hope more questions are coming in so that we can clear some misconceptions and myths with regards to prostate cancer, the prostate. So we can start with the cutoff age. There is no exact cutoff age for PSA screening in older men. However, we would like to really use the patient's or the individual's fitness as a guide, and also how we can predict the life expectancy. Ideally, we base the screening limit compared to the national life expectancy and whether or not this patient with his pre-existing diseases should be able to live for more than 10 years. Then, because what happens is that if the individual is fit and healthy and able to live or outlive the nation's life expectancy for a significant time, then treatment will be beneficial, because the treatment for prostate cancer and even the workup for prostate cancer is rather arduous and can cause significant morbidity. Thus, the selection of patients who goes for screening needs to be really, really tight, and we need to understand the risks and benefits involved in performing PSA screening. So there, to answer your question, there is no absolute cutoff age. There's no specific number. We base it on the patient's general condition and also how we expect the patient to live for a significant period of time, for what I think is more than 10 years.
All right, thank you, Dr. Zainal. So next question that we have, are there any specific lifestyle factors or habits that could actually contribute to the enlargement of the prostate or in specific prostate cancer?
I get asked this a lot with regards to dietary and lifestyle changes. However, sad to say that there are no specific lifestyle changes that can be done to prevent or reduce the risk of prostate cancer. It is more related to bladder training to improve your quality of life when the symptoms of the lower urinary tract come to you. So we would want to practice good bladder habits. For example, passing urine before you go to sleep to prevent you waking up in the middle of the night. Training your bladder so that you are able to hold in urine for a little bit before finding a toilet, so that the situations are more acceptable to you, rather than urgently getting to the toilet and, causing accidents or falling. So these are some lifestyle habits that can be done to improve or train your urinary system, but there are no specific advices for prostate cancer.
All right, thank you, Dr. Zainal. So next question that we have, what are the potential complications for untreated prostate enlargements? Meaning that patient who has known to have a prostate enlargement, but they just don't bother to get treated.
Well, with prostate enlargement, as I mentioned in the talk earlier, size does not really dictate symptoms. We really go by symptoms. If the patient has an 80 or 90 gram gland, however, is unbothered by his urinary symptoms, I would say that my advice would be to take a PSA, because prostate cancer will not show itself until it's really late. So it's prudent to get at least some bit of testing. However, if the symptoms don't bother you and you have been screened to be negative, or you're not at risk to get prostate cancer, then by all means, you should just continue your healthy lifestyle. But having said that, a larger gland kind of predicts that you will be developing some sort of complications from prostatic enlargement. Thus, you should be on the radar of a urologist or a general practitioner, so that we know when to initiate treatment for you.
I totally agree with that, Dr. Zainal. So we have a question from Madam Nurul Ashikin. Assalamualaikum, doctor. What is the suggestion for frequency of checking prostate?
I assume that the frequency of checking the prostate should mean that either blood testing, the PSA. I personally start screening patients when they are 50 above. If they have a family history of prostate cancer, I would do that a little bit earlier, maybe more than 45. But if you have been worked up once for prostate cancer and it all turns out to be negative, then I usually advise them to go for an annual sort of like symptom and clinical examination, so that we are aware that these individuals are within our radar and we can initiate them treatment or more workup if indicated. However, if we talk about the evidence, I think in the guidelines, if you have already one negative PSA, which is not above the limit, then there are intervals of upwards of 5 years before you do another one.
All right, thank you for that. And we have a question from Madam Siti Anisah Jamaluddin. Alpha blockers in BPH, which is a prostate enlargement. How long does it take to usually to show improvement in symptoms and any dose recommendation or dose titration?
Basically, when it comes to alpha blocker treatment for benign prostatic enlargement or even to improve symptoms of the lower urinary tract, I advise patients to take it minimum of 7 to 10 days before it shows any significant effect. And then, so the second part was dose titration. Usually, the dose that is given for the alpha blockers are usually already at suggested or max dose. I rarely use any increased dosage for alpha blockers. It is used as it is, and we don't really advise for taking double the dose because the clinical effects are similar based on the trial.
Thank you. And the next question from Mr. Laksamanan, what is the threshold size of prostate that needs serious attention?
What is threshold? I guess, as you've mentioned, that size does not really dictate how or when you seek treatment. It's more of the symptoms. If you're aware that there is something off about your urinary habit, meaning either you are passing urine a bit more frequently or you feel like there's a bit more urgency when you get that feeling, or you're incompletely voiding, meaning at the end of it, you still feel like there's something or some urine left inside, then it's prudent to get checked. I wouldn't say you should base it on size completely.
So since we have some time, there's one last question from Mr. Laksamanan, even though it's not directly to the prostate enlargement. So the question is, what could be a basic, simple oral medication approach to urinary infection? So maybe Dr. Zainal can just give a simple answer to that.
I think when you talk about oral medication to prevent urinary infection, I think nothing beats good urinary habits rather than medication. To ensure that hygiene of the external genitalia is maintained, you empty your bladder completely, either by double voiding or time void. This is much better to prevent urinary infection. However, there are some preparations that you can drink to prevent urinary tract infection.
All right, so that will be the last question for the Q&A session for Dr. Zainal. Thank you, Dr. Zainal, again for being one of our speakers. Our great honor to invite you.
All right, it's been a pleasure. Thank you very much, and congratulations to the University of Malaya Urology team. This is very impressive. Thank you.
Thank you. All right, so without further ado, we'll move on to the next speaker. So it's our great honor to invite our next speaker, come from the Borneo, with the topic can supplements help with prostate health? For example, saw palmetto. So we have Dr. Aaron Goh Yu Keng, consultant urologist from Sarawak General Hospital, has a broad research experience and have presented in many conferences such as Malaysian Urology Conference, Urological Association of Asia Congress. So we'd like to invite Dr. Aaron Goh for the next topic. Thank you.
Thank you, Chairperson, for the introduction, and congratulations to the University Malaya team for organizing such a successful public seminar to bust common urological myths. My name is Dr. Aaron Goh, currently serving in Sarawak General Hospital, and I'm excited to have been invited to present on this topic, which I find to be very relevant in view of the explosion of popularity of health supplements among Malaysians, where 1 in 4 are consuming at least one type of supplement daily, based on a 2019 survey. In this lecture, we will take a look at some of the common supplements for prostate diseases and see if they really work or just a waste of money. We will keep the lecture quite simple by first going through what the prostate gland is all about and what can go wrong. Then we will have a look at the common ingredients in prostate health supplements and go through recent literatures to determine if they really work. So let's begin. What is the prostate? The prostate is a walnut-shaped gland which wraps around the water pipe deep in your lower abdomen, somewhere around here. Its main function is to produce part of the fluids in a man's semen, and it tends to grow to an adult size when he's about 20 years old. Some may grow further when a man reaches his 40s, and as the gland enlarges, the water pipe may get obstructed and, like a clogged drain, causes urinary problems. In general, three main problems can occur in the prostate. First and commonest is benign prostatic hyperplasia, or BPH, which is an age-related enlargement of the prostate. Prostatitis is inflammation or infection of the prostate gland. And lastly, and most worryingly, would be prostate cancer, which is now the third most commonly diagnosed cancer and fourth leading cause of cancer deaths among Malaysian men. We will be focusing on BPH in today's talk, and it's important to note that while each of these conditions affect the prostate differently, all may cause similar symptoms, and some unfortunate men may have all of these conditions concurrently. So what is BPH? BPH, as the name suggests, is a non-cancerous condition affecting the prostate gland where there is more cells than usual. The usual size of a prostate gland is about 20 cm3, and in BPH, the size may grow up to 5 or even 6 times the normal, as seen in the image on your right. This may lead to uncomfortable urinary symptoms as the outflow of urine is blocked by the gland, but the size does not always correlate with severity. So you may have a small gland, and yet the symptoms are very bothersome. And who gets BPH? BPH is generally referred to as disease of the old. The size of the prostate remains essentially unchanged after it has grown to an adult size at about 20 years old. However, among men between 51 to 60 years old, the prevalence of BPH is about 50%, and its size usually doubles every 10 years until the age of 70. Studies have also shown that obesity, higher BMI, and a lack of exercise may increase the risk of BPH. Among Malaysian men, based on a study done in Hospital Kuala Lumpur, the prevalence of BPH among men aged above 50 was close to 60%, with 1 in 5 having severe symptoms. So what are the symptoms in BPH? They can be divided into either trouble with urine storage or urine passage. Storage issues include frequency, urgency, and occasional leakage of urine, while passage issues are trouble starting urination, poor stream, the need to strain, incomplete emptying, and the worst of all, inability to pass urine at all. Unfortunately, Malaysian men are quite accepting of their symptoms and rarely complain about them until quite an advanced stage. Sometimes in a busy clinic, I found a simpler way to assess if they have BPH symptoms by asking 2 simple questions. Do you take longer compared to your friends when you go to the washroom? And is the toilet your friend? If the answer to any of these 2 questions is yes, I will spend a little bit more time assessing them properly, and usually they will need some form of treatment. But of course, this does not apply if all of your friends have BPH. As a result of these symptoms, many men have experienced negative impact on their quality of life due to the need to adjust their normal lifestyles around their urinary habits. Poor sleep is a major issue, as among the elderly, those who slept under 5 hours per night were twice as likely to develop dementia, according to a study by the Harvard Medical School. If you were to see a urologist today for these symptoms, quite likely you will be offered one of 2 options. First would be medical therapy, and second would be surgery. Medications for BPH are generally classified into 2 groups, one of which are alpha blockers, which will provide almost immediate relief by relaxing the smooth muscles around the prostate. The second of which are 5-alpha reductase inhibitors. These are to shrink larger prostate glands, and both of these can be taken in combination. The second of which are surgeries, which, as you see in the photo, is the insertion of camera into the prostate gland and resecting the gland piecemeal to widen the channel and allowing better urine flow. Nowadays, there's also the option of injecting steam into the gland, which will allow it to shrink slowly over time. These will generally take longer than the conventional surgery. But there is always the avoidance of treatment due to the fear of side effects, which has brought about the explosion of health supplements. Many naturally will turn to health supplements to either prevent or self-manage their BPH symptoms. And the Malaysian market is now worth a whopping 3.1 billion ringgit. But do they work? Many products are available in the market claiming to improve prostate symptoms, and most do so by reducing inflammation. Usually, the bolder the claim, the higher the price. But do they work? That is the million-dollar question. For the purpose of this talk, I've gone to the most popular online marketplace in Malaysia to look at the prostate supplements with the highest sale volume. Each of these items seem to have a combination of different ingredients. Some also have the additional side effects of improving libido and erection. But we will exclude them and focus mainly on those related to BPH. For my survey, it seems that the commonest ingredients are those listed here, with those in green being the commonest. So let's have a look at each of them and see if they truly work. The first ingredient is probably the best studied one, which is saw palmetto or Serena repens. It is extracted from ripe berries of the American saw palmetto plant and is widely used to improve BPH symptoms. The mechanism of how it works were not fully understood, although numerous proposals have been made, including inhibition of 5-alpha reductase, similar to the medical therapy that we usually use, anti-androgenic effects, anti-proliferative effects, anti-inflammatory effects, and anti-edema effects. Studies on saw palmetto is probably the most widespread among the different ingredients due to the commercial value of its ingredient and the popularity in the United States. The most robust study regarding its efficacy was a trial published in JAMA where multiple dosing of saw palmetto, up to even 3 times the usual dose, failed to result in any improvement of their symptoms. This year, Cochrane updated their review on this topic, which was first published way back in 2012. And after almost a decade, they managed to find 27 studies involving about 4,000 men and reach a similar conclusion as 10 years ago, that saw palmetto resulted in little to no difference in urinary tract symptoms or quality of life compared to a placebo. One may think that since it's a herbal therapy, a longer duration may be all that is needed to see the benefit. However, there were longer-term studies on this issue, up to a year in the STEP study and about 1.5 years in the Cayman study, all of which also showed that there is no benefit compared to placebos. Since the last Cochrane review in 2012, investigators have started, instead of focusing on a single agent, they have studied combinations with other ingredients commonly used to treat prostate symptoms due to the lack of efficacy. In this 2014 study, saw a combination of saw palmetto, lycopene, and selenium with tamsulosin, and it was found that if we were to add these supplements to our conventional medical therapy, the result seems to be synergistic. You get better improvement in your symptoms. A separate study comparing similar combinations with tadalafil also showed similar benefits. And this shows that despite their lack of efficacy on their own, when added to conventional medical therapy, they seem to have some positive benefits. So in summary, the overall research has failed to show any benefit even with higher dosage of saw palmetto. But the combination with other ingredients and medical therapy seem to have some beneficial effects. But the method of extraction of this saw palmetto is important because those who are extracted using ethanol is not as good as those that are hexane extracted. While it's generally considered safe, saw palmetto may not be tolerated by some individuals, as there have been reported side effects including headache, dizziness, nausea, constipation, and some allergic reactions. The second ingredient is beta-cytosterol, which are naturally occurring steroids produced by plants with similar chemical structure as cholesterol. Commercial ones are commonly derived from the South African stargrass or pines. Products are often promoted to improve urinary symptoms and prevent prostate cancer, but the mechanism through which it works remains uncertain, but probably through potent antioxidant and anti-inflammatory properties. One large-scale review can be found for beta-sitosterol, which was performed by Cochrane in 1999. They suggested that sitosterol may improve urinary symptoms and flow measures. However, the long-term efficacy, safety, and ability to prevent BPH are not known, as most of these trials were short-term, lasting about 4 weeks to up to 6 months, and they were all conducted in the 1990s and had small groups of patients with gaps in reporting. So possible short-term benefit, but outdated trials. Overall, research has shown benefit compared to no treatment at all based on small studies. But if they were clinically useful, by now it would have been used more widely. So I would take it with a pinch of salt. While it's generally considered to be safe with occasional mild gastrointestinal side effects, there have been reports of interference with efficacy of other drugs, so care should be taken if you are on multiple medications. The ingredients are also present naturally in some fruits, nuts, and oils, so perhaps those are cheaper ways to supplement beta-sitosterol into your diet. The third ingredient is pygium, which is extracted from the African cherry tree bark and has been used for a variety of medicinal purposes by the natives for centuries. The mechanism of how it works is uncertain, but probably through anti-androgen and anti-inflammatory properties similar to beta-sitosterol, as the active compound is probably a plant steroid. As for the use of pygium, there was only one large review available, again from Cochrane, published in 1998, where 18 trials involving 1,500 men were included. All of these studies compared pygium to no treatment at all, and none compared these to conventional medical therapy. Based on their review, pygium is useful to improve symptoms of BPH compared to no treatment at all, but they did warn about interpreting these results as studies were again small in size and of insufficient quality, with variable preparations. So, similar to beta-sitosterol, short-term benefits based on outdated trials. Again, similar to the case in beta-sitosterol, if these were to be really efficacious, it would have seen a wider use by now. Pygium is again considered safe with occasionally mild gastrointestinal related side effects. The next ingredient is lycopene, which is a naturally occurring carotenoid or organic pigment found in some fruits and vegetables. It is a potent antioxidant. However, based on a review in 2012, all studies done using this product were of poor quality and no conclusions can be made. There were also issues with its safety, as there has been reported side effects of hypotension, gastrointestinal problems, and increased risk of bleeding. Nettle root is another ingredient which is harvested from the roots of the stinging nettle plant. How it works is uncertain, but probably an antioxidant and anti-inflammatory agent. A review in 2007, which had only one trial, showed small benefits, but it is generally safe for consumption with mild gastrointestinal side effects. Pumpkin seed oil is another ingredient that is commonly seen and usually used as an anti-inflammatory agent. A trial done in 2021 comparing tamsulosin, which is a commonly used agent for BPH, versus pumpkin seed, showed that while pumpkin seed has some beneficial effects, it is not as good as medications. But they are generally considered to be safe, except again for some gastrointestinal side effects. Flower pollen extracts from ryegrass, corn, or timothy grass with anti-inflammatory effects are also sometimes included in health products. A review in 2011 found that they were better than placebo, but trials were of poor quality, and again, they are well tolerated in general. It is also important to mention the roles of vitamins and minerals in the prevention of prostate diseases, especially prostate cancer. Zinc, selenium, vitamin E, and vitamin D have all been studied in their role of preventing prostate cancer. However, all these trials were inconclusive, and some found that a higher amount of these vitamins and minerals in your body actually increases the risk of prostate cancer by up to 17%. So while they are safe in general, are generally not recommended for prostate health. So in summary, when it comes to supplements for prostate diseases, the overall evidence of efficacy is weak. Some are ineffective, and some are even harmful, as in the case of vitamins and minerals in the prevention of prostate cancer, and are not recommended in any international treatment guidelines. I would discourage them from being used in men with significant symptoms, but most are generally safe to consume. So perhaps their role is to be used as an add-on to medical treatment instead of replacing them, as some studies have shown that a combination with medication has led to increased efficacy. So with that, thank you for your attention, and I'll be happy to take any questions you have during the Q&A session. Thank you very much.
Thank you, Dr. Aaron.
Hi, good morning.
Hello, hi. So thank you, Dr. Aaron, for the very interactive talk. So it's quite an eye-opening for all the topics regarding the sulfametopygium, because this is sort of a lot of patients came to see us with all these supplements, and we are quite unsure how to answer them. So from the Q&A session, so we have a question from Mr. Muhammad. Any foods that can help shrink the prostate, or any foods that can need to be avoided to prevent prostate enlargement?
Thank you for the question. I think I get asked this question a lot because many of us try to, adjust our lifestyles and hopefully prevent progression or complications from disease. But unfortunately, prostate enlargement is a symptom that comes with aging. It's part and parcel of that. So there's no food that's proven to shrink prostate glands so far. If there's any, then I think it will be a very, very, very interesting thing. But unfortunately, there's none at the moment.
All right, move on to the next question. Where can individuals find reliable information about prostate health and supplements?
Oh, when it comes to men's health, actually, there's a website, the Men's Health Clearinghouse, that has discussions on all the common men's health issues, prostate health, erectile function, or even just healthy male aging. So generally, there are a lot of articles on that on the website that I used to refer to. But overall, if you go to any reliable website online, something like Medscape for patients, or even some guidelines that are watered down so that lay people can understand, those are very reliable, and I would think that it would be better than any messages that you get through WhatsApp, which is always quite dubious. So try to find reliable sources online, but make sure to counter check where they get their information from and where they are referring, like any articles or evidence they're referring to when you are doing that. I think if you do that, it's generally quite safe. So any website would be okay if it's going through.
All right, so we have a question from Mr. Ramanathan. Some studies say ashwagandha and herbal medicine is useful. What is your opinion on that?
Yeah, I did come through that during my research, but unfortunately, no article on that has been done. So there is no recommendation for or against. You will have to check the ingredients inside. Sometimes it's just a branding. If it's an ingredient that you're mentioning, there's no evidence. If it's just a branding, you look at the ingredients. Maybe some of them have been included in the talk earlier. You have to check it out.
All right, thank you, Dr. Aaron. So we have a question from Madam Nurul Ashikin. Hello, Dr. Aaron. If the supplement shared by just now, is the supplement will be prescribed as suggestion with research study, or is depend on the individual? So I think I'll leave it to you to answer the question.
So the ones that were discussed just now, these are based on research, meaning these ingredients have been studied. Patients are split into two groups, one taking this supplement and one just maybe a sugar pill, and they compared the efficacy in a very controlled and monitored way. So all of these have been studied, and the research that I discussed earlier are based on the publications from this study. Based on individual, as I said, why do some people get diabetes if they eat a lot of sugar? Why some don't? It's also partly individualized, the response to any supplements. So it probably best of both worlds. You need to see the evidence, and also if you take it, if you see some benefit, I don't think that it's harmful.
So thank you for all the answers. So we have one more question. Check again. All right, from Mr. Laksamanan. Some years ago, I remember reading a newspaper clip about saw palmetto as miracle product. So what is your say? Can you just summarize about what your findings about your saw palmetto just now?
Yes. Saw palmetto was a big thing, I think about a decade ago, because one thing you have to understand is saw palmetto came from the US. And whenever something comes from the US, generally there are a lot of publications, many of them. Some of them would have been done in a small scale, some in a very large scale. So like Dr. Zainal mentioned earlier, when we are taking evidence, relying on an individual trial is quite tricky because some of the trials are performed perhaps in a not high quality type of way. So summarizing these trials together, including all their findings, then analyzing the details of all these trials when combined would be a better evidence. And based on the evidence that we have now, saw palmetto on its own is unfortunately not beneficial in preventing complications or progression of BPH. But they're generally quite safe to be taken if you want to take them for your own personal health.
All right, so I think that should be the last question for this Q&A session. So thank you, Dr. Aaron, for your time. And
Thank you. It's very nice to be back to UM, even virtually.
Thank you, Dr. Aaron.
All right, thank you.
All right, so without further ado, we'll move on to our next plenary 2. So next plenary 2 will start with a very interesting topic, with a topic of breaking the silence overcome with erectile dysfunction. So this is topic very bad stigma amongst population. So we try to come up with the topic this year. So our next presenter is our great honor to invite our own team. This is Dr. Chai Chu An, consultant urologist from University Malaya Medical Center. He have a very good interest in endourology and andrology, which completed his fellowship in both in Edinburgh, Scotland. Has multiple recent publications recognized internationally. So without further ado, we invite Dr. Chai Chu An for the next lecture.
Hello everyone. Thank you very much for attending this webinar entitled Breaking the Silence, Overcoming Erectile Dysfunction. Our objectives today are to increase awareness and understanding of erectile dysfunction, as well as to provide an introduction to available treatment strategies.
What is erectile dysfunction? ED is defined as the inability to obtain or maintain an erection sufficient for penetration and the satisfaction of both sexual partners. The global prevalence of erectile dysfunction is reported to be 52% among men aged 40 to 70 years old. The prevalence of ED in Malaysia is not far apart. In fact, 69% of men less than 80 years old have some degree of erectile dysfunction, with 33% reported as mild ED, 26% moderate, and 10% severe. However, these unfortunate men mainly suffer in silence, as up to 90% of them do not seek treatment for various reasons. Embarrassment, ignorance, and procrastination are major factors. It is also interesting to see that a large number of patients attributed their lack of treatment to not being asked upon by their attending doctor. But I would like to bring to your attention that the penis is actually a health barometer. Studies have shown that ED is an early warning sign of many serious underlying pathologies, such as coronary artery stenosis, diabetic peripheral neuropathy, retinopathy, hypertensive cardiomyopathy. In relation to coronary artery disease, which is the #1 killer for the Malaysian population, there is a strong correlation between erectile dysfunction and cardiovascular disease. In fact, they share almost identical risk factors such as hypertension, hyperlipidemia, diabetes, obesity, lack of physical exercise, cigarette smoking, and poor diet. In association with diabetes mellitus, the incidence of erectile dysfunction is 5 times higher in patients with diabetes mellitus, and more than 35% of patients with diabetes mellitus suffered from erectile dysfunction. Patients with diabetes mellitus are also at risk of developing ED 10 to 15 years earlier. They are usually more serious, more resistant to oral treatment, and have a worse quality of life. Erectile dysfunction is also closely related to depression. In a systematic review of 49 publications involving 169,000 patients, the risk of erectile dysfunction increases by 39% in patients with depression. Furthermore, erectile dysfunction increases the risk of depression by almost 2-fold. Besides from the mentioned causes and risk factors of cardiovascular disease, metabolic disorders, and psychogenic factors, ED can also be caused by underlying hypogonadism, medications, and previous trauma or pelvic surgery.
I hope that I have managed to convince you that erectile dysfunction is not just a quality of life issue. It is important to seek professional help to address your expectation and to clear off any of your doubts while providing a tailored solution for you and your partner. So what should you be expecting when you inform your doctor regarding the issues of ED? The doctor will usually hope to obtain a complete medical sexual history, focused physical examination, and laboratory investigation before discussing with you regarding the options of treatment. A detailed sexual history usually involves asking regarding the duration and onset of erectile dysfunction, any presence of low libido which might suggest hypogonadism or low serum testosterone, any lifestyle factors or presence of any nighttime or early morning erections.
The simplified IIEF-5, which stands for International Index of Erectile Function, is a validated questionnaire for assessing patients' confidence and ability to perform sexual intercourse over the past 6 months. It scores from 5 to 25, and a lower score indicates worse erectile function. Alternatively, the EHS or erection hardness score can be used. It has 1 domain and 4 gradings, and is easier for patients to correlate. A detailed history and physical examination on exercise tolerance are paramount, especially for patients who are at risk. Essentially, sex is a moderate physical activity which equals to walking 1 mile in 20 minutes or briskly climbing 2 flights of stairs in 10 seconds. Cardiac risk stratification is based on the Princeton consensus. Patients who are in the intermediate and high risk category are required to be referred to a cardiologist for assessment and stress tests before initiating erectile dysfunction treatment. The laboratory investigations routinely sent are fasting blood sugar, serum lipids level, and investigation for hypogonadism. Advanced workup on erectile dysfunction is not routinely performed. It is used if there is a diagnostic dilemma or if there is a need to diagnose the type of erectile dysfunction. Intracavernosal injection tests coupled with penile duplex ultrasound can be used for identification of vasculogenic erectile dysfunction, whereas nocturnal penile tumescent test is used to rule out psychogenic ED.
Traditionally, the treatment strategy for erectile dysfunction involved a step-ladder approach from lifestyle modification to penile implant insertion. However, it is now recommended that all options apart from the implants are to be made available for the patient, and treatment approach should be a shared decision between the patient and treating physician. Lifestyle modification has a huge impact on the quality of erection. The main pillars for lifestyle improvement are regular exercise, healthy diet, stress management, weight reduction, and stop smoking. A meta-analysis involving 28,000 patients showed that smoking 10 cigarettes a day increases the risk of erectile dysfunction by 14%. The erectile dysfunction risk is also increased in being a passive smoker. Patients who quit smoking have improvement in erectile function by 25% in 1 year. It is also important to identify and correct any reversible or modifier risk factors for erectile dysfunction, namely diabetes mellitus, hypertension, hypogonadism, or BPH. In a study involving 12,000 men treated for benign prostatic hypertrophy, 49% are found to have some degree of erectile dysfunction, of which 10% of these had severe ED. A 5-year follow-up on patients who had surgery for BPH showed no significant impact on the worsening of their erectile function. Ever since Viagra introduction in 1991 as a failed drug for treating cardiovascular disease, it revolutionized the treatment of ED. There are currently a variety of PDE5 inhibitor options available. Besides PRN doses, a daily 5 mg dose of tadalafil is currently available as a treatment option for both ED and BPH. It is important to remember that nitrates use is an absolute contraindication for patients on PDE5 inhibitor, as this will result in cGMP accumulation and drastic falls in blood pressure, causing severe hypotension. Based on the half-life of each drug, if a PDE5 inhibitor is taken and the patient develops chest pain, nitroglycerin must be withheld for a total of 24 hours in case of sildenafil and vardenafil, 48 hours in case of tadalafil, and at least 12 hours in case of avanafil. For patients who are on alpha blockers for treatment of BPH, the latest meta-analysis of 19 randomized controlled trials showed that concomitant treatment with alpha blockers and PDE5 inhibitor does not increase the rate of adverse events due to hypotension. The authors suggested that uroselective drugs such as alfuzosin, tamsulosin, and silodosin should be prioritized. Alternatively, patients can opt for a daily dose of tadalafil 5 mg, which is recommended for treatment of both BPH and erectile dysfunction. The side effects from PDE5 inhibitor occur in approximately 10 to 15% of patients. The common side effects are headache, flushing, nasal congestion, with more specific side effects such as back pain occurring in patients taking tadalafil. The newer drug avanafil seems to have the lowest side effects profile. Failure of treatment is defined as 6 attempts of optimal usage and dosage with a particular drug. The most common causes of failure are inadequate sexual stimulation, inadequate dosage, and inadequate time between taking medication and sexual intercourse. In case of non-responder, there is an option of considering switching to a different PDE5 inhibitor or trial of combination therapy. Prostadil or Coverjet is the drug used for intracavernous treatment of erectile dysfunction. Patients are required to learn the self-injection technique. where a fine needle is injected over the lateral aspect of the penile shaft into the corpus cavernosum. The time to erection is approximately 5 to 15 minutes. Due to the fear of needle, this option is seldom preferred and has a high dropout rate of approximately 68% due to a high rate of needle site pain or discomfort. There's a small risk of prolonged erections, priapism, and fibrosis causing Peyronie's disease. The vacuum erection devices provide passive engorgement of the corpus cavernosum together with a constrictor ring at the base of the penis for retention of blood, thus maintaining an erection. Published data has reported a satisfaction rate for penetration to be as high as 90%. However, the ring has to be removed within 30 minutes to avoid the risk of skin necrosis. The dropout rate is 50% and is usually within 3 months, with the main adverse events being pain, inability to ejaculate, petechiae, bruising, or numbness around the area of the constricting ring. Therefore, the vacuum erection device is contraindicated for patients with a bleeding disorder or on anticoagulant therapy. The low-intensity shockwave therapy is currently advocated for treatment of vasculogenic ED. In principle, the shockwave induces microtrauma, leading to angiogenesis and recruiting new stem cells, promoting an increase in perfusion and penile blood flow. However, the overall reported patient satisfaction rate differs greatly from 40 to 80%. This is partly due to heterogeneous data on technical specificity such as generator types and setup as well as treatment protocol. The ultimate options for treatment of erectile dysfunction is the penile prosthesis. There are currently 2 types, the semi-rigid malleable or the inflatable type. The inflatable penile prosthesis is usually more preferred among patients as it appears to be more natural. The penile prosthesis may be considered in patients who are not suitable for different pharmacotherapies or prefer a definitive therapy and do not respond to other treatment modalities. It provides the highest satisfaction rates to both the patient and his partner among all treatment modalities for erectile dysfunction. At the same time, has a small risk of mechanical failure, infection, and erosion risk. In conclusion, I would like to highlight that erectile dysfunction has become commoner with increasing age and is seen in up to 60% of men in Malaysia. It is often associated with obesity, high blood pressure, high cholesterol, and diabetes, which are all significant risks to health. ED can also be a precursor to cardiovascular disease. The treatment of erectile dysfunction are mainly lifestyle modification, oral medications, intracavernosal injection, vacuum-assisted devices, low-intensity shockwave therapy, and penile implants. Before we end, I'd like to emphasize that distance doesn't separate people, silence does. So, let's break the silence and let's overcome erectile dysfunction together. Thank you.
Thank you, Dr. Chai, for the interesting talk. So we have a lot of questions actually from the floor. So we start with the first question. Actually, this question was asked from the previous lecture. So I think this question is more towards, I think you'll be the better person to answer it. So from the anonymous, it was asking about the issue. How do they have a blood stain in semen? So how do you approach it?
Right. All right. Thank you very much, Dr. Shahada. Yeah. Thank you. Good morning, everyone. So with the issues of blood stain semen, it's what we call hematospermia. Usually it's self-limiting. It should stop after 1 to 2 months. If it does not, probably you would will need to get help or medical treatment. There are different reasons for why there could be blood stain in your semen and sperm. It's because it could be due to a BPH or very vascular prostate, and then during ejaculation there could be some blood stains. That could be benign cause, or it could be infection, underlying prostatitis, for example, or the presence of any stones in the seminal vesicles at times. So usually these factors are self-limiting, and however, if it does not stop, we should probably get help and get medical treatment, and we should investigate further.
All right, so move on to the next question. What is your say in private clinic GP? They are advertising on Facebook about penile injection, penile corpus wave treatment. So what are your say about that?
Right, penile injection, yes. It depends on what particles or materials or what sorts of injections are being recommended or provided. I'm aware that nowadays in the pipeline there's platelet-rich plasma, right? Which is now in trend. However, we can't recommend platelet-rich plasma injection intravenously because the data or the evidence is not strong enough. So currently, according to the EAU guidelines, which we practice upon, platelet-rich plasma injection is based on clinical trials. So we await stronger data for us to advise or suggest to our patients in that regards. As for a prostatule or coverjet injection, this is it is part of the armory or the armamentarium which we provide our patients with options of treatment of erectile dysfunction. So if they are comfortable with injection intravenously, then this is one of the options available for the patients, especially for those patients who are not responding well to oral medications. Yeah.
I guess they have to find out in details what are the advertisement for. So the next question is from Mega Subra. Erectile dysfunction, is it reversible?
Well, very good questions. I would say yes and no. Yeah, it is reversible if the main cause of erectile dysfunction is psychogenic. So performance anxiety, right? So that's very reversible actually. You probably will need to get help from your GP, your general practitioner, or your urologist, which we can also supplement you with some oral medication together, and then some sexual counseling from our experts. Then it is very reversible for psychogenic ED. The reversible causes of erectile dysfunctions are the underlying causes such as poorly controlled diabetes mellitus, hypertension. These can be somewhat reversible if they are treated and well controlled early, and supplement with oral medication. They can patient satisfaction can be pretty high at times. However, if the control is poor and the patient developed the patient will and eventually might develop irreversible erectile dysfunction. But afraid not, you have to open up to your doctors and your general practitioners as well as your urologists. Then we have multiple methods that we are able to help you to achieve adequate and satisfactory erectile functions.
Thank you for the very precise answer, Dr. Chai. So since you mentioned about performance anxiety, so actually we have a question here. How do they actually overcome the performance anxiety in terms of erectile dysfunction?
Well, yeah. So this is quite a personal question there. Well, it depends. It depends on person to person and from patient to patient. What causes the performance anxiety? Is it from the patient's angle, or was it performance anxiety induced by your partners or your peers? We have to speak to you personally, identify what is the cause behind, what causes you to be anxious in the first place, and then we can gradually help you to remove the causative factor. Yeah.
Next question, what lifestyle changes can individuals adopt to potentially reduce the risk of getting erectile dysfunction?
Lifestyle changes, yeah. So healthy lifestyle is very important for prevention of erectile dysfunction or to improve. The main pillars, as I mentioned, is for a healthy lifestyle is weight monitoring, and then stop smoking, moderate alcohol intake, as well as to control underlying metabolic problems such as hypertension, diabetes, as well as obesity. Bear in mind that these do not just prevent erectile dysfunction, these can also help prevent other chronic medical illness as well.
Let's move on to the next question. Since this topic is quite sensitive, so what steps can someone take to initiate a conversation with their doctors about this topic, about this condition?
Thank you for a very good questions there. Well, yes, erectile dysfunction is pretty sensitive. It's pretty personal, and it takes a lot of it takes someone to be very brave and a lot of guts to actually open up and inform regarding this underlying problem. I guess bear in mind that your medical doctors are all well-trained professions. I'm pretty sure that we are very well-versed and we receive such questions from our patients all the time. So we are very comfortable in engaging and providing the correct advice. At the same time, I would like to ensure you that for us medical professions, it's our duty to also to take care of your personal detail and data, and no one else should be aware of this. So when you speak to your medical professions, a good start would be if you already have a personal general practitioner whom you always go to, that would be a great start to open up to them. If there's a need to, they can refer you on to the urologist as well. And then we will start to work up on how to start and diagnose and treat your erectile dysfunction.
Thank you, Dr. Chai. So the next question, can someone take Viagra even they don't have any problem with erection?
Well, so for your information, yeah, that's a very good question. Viagra or sildenafil, it's not an enhancer. Yeah, so it helps for you to maintain erection if you have an ED, but it does not improve your performance per se, right? Well, we do give Viagra if the patients might have some psychogenic ED to help the patient to tie over when he's trying to overcome the psychogenic factor. But we do not routinely provide patients with Viagra to enhance their performance in sexual intercourse.
All right, so the next question, very interesting questions. So can overstimulation cause erectile dysfunction? Example, frequent self-masturbation as complained by some patients.
Well, yeah, so I guess the answer to the question is overstimulation causes ED. Probably not that I have came across. But if there's any trauma or any micro trauma which due to the overstimulation, which subsequently the patient develop complication from this, which develop formation of plaque or fibrous tissue, which causes anatomical deformity or Peyronie's disease, this can subsequently lead to inability to perform adequate penetrative intercourse or even ED.
So next question, ED is a social stigma. What is your early educational advice to the society?
Well, I guess everyone plays a very important role, in spreading correct information, precise detail on the education of ED, and then of course, social-wise, with the advancement of technology and information, every information easily can be gotten online. So people, patients especially, will start to open up, and also support from family and peers on your relatives or friends who have ED, and advise them to not to be shy to seek medical advices. That would be the way to go forward.
So since we have some time, so there's a few more questions. So how do we screen for erectile dysfunction? Do you think is it beneficial to do screening in general population?
No, we do not screen for erectile dysfunction, Dr. Shahada. Yeah, because it is, first of all, it is in our community, it's also considered as a social disease as well. Yeah, unless erectile dysfunction is being treated if the patient has got is sexually active, right? So if the patient is not sexually active to begin with, then usually we would not advise on treatment for erectile function, because the treatments essentially will need sexual stimulation. And then instead of screening for erectile dysfunction, usually what we have been practicing at all levels of medicine is that we screen for chronic medical illness such as cardiovascular disease, as well as diabetes and hypertension. These are the essential diseases which we screen. But because erectile dysfunction is closely related to all these chronic medical illnesses, usually we will advise our colleagues to at the same time ask if erectile dysfunction is an issue.
All right, since it's quite a hot topic, so we got one more question. So
Yes.
Question is, please enlighten on the myth of Viagra and cardiac arrest.
Well, yes. So as I said in one of my slides, that that sexual activity is a moderate physical activity. So the patients with cardiovascular disease, we will take these group of patients very cautiously when we're treating them, to ensure that they are clinically fit. Well, if they are not, or if they came with background history of cardiovascular disease, and we think that this will be an intermediate or high risk patient, we'll therefore refer them to the cardiologist before we initiate any treatment for erectile dysfunction. Essentially, they will need to undergo a stress test to see if they are fit to perform this moderate physical activity. On the other hand, for patients who are known to have cardiovascular disease and who has known with history of angina, who is or previously been taking nitroglycerin or nitrates, these are the patients who should not be taking PDE5 inhibitors or Viagra.
Thank you for the answer, Dr. Chai. So we have a last question. So since we are talking about erectile dysfunction, so what are the available treatments option for ED in the government and private practice in Malaysia?
Well, right. Thank you very much for the questions. I can't really say for private practice because I'm not in one. Yeah, but for government practice right now, for example, in University Malaya, we have widely available range of treatment. We have oral medications. We have intracavernosal injection, which is the Coverjet or Acrostidyl. And then we can easily source vacuum-assisted devices. And for your information, we are also getting in the low-intensity shockwave therapy in University Malaya soon. So we'll be hoping to start the treatment for our patients who are mainly due to vasculogenic ED. And also good news is that we can also provide services of penile implant insertion for patients who have tried other methods of erectile dysfunction and which has failed.
All right, that should be the last question. Thank you, Dr. Chai, for a very good answer for all the questions. And it's a great honor to have you as one of our speakers for the very hot topic. All right, thank you again.
Thank you.
So we move on to the next topic for plenary 2. So we have a topic of crushing the obstacle, confronting kidney stone. What steps can I take? So the next presenter, we are greatly honored to invite this next presenter, Dr. Christopher Lee Keng Siang, consultant urologist in Hospital Sultan Abdul Aziz Shah UPM, completed his fellowship in urology in the Alfred, Melbourne. So without further ado, we move on to the next topic. Thank you.
Good morning. My name is Dr. Christopher Lee, and I'm a consultant urologist at Hospital Sultan Abdul Aziz Shah, University Putra, Malaysia. Today, the title of my talk is Crushing the Obstacle, Confronting Kidney Stones. What steps can I take? This is an overview of my lecture, which consists of a few common questions. What are kidney stones? Who gets kidney stones? And what are the symptoms? What should I do if I have these symptoms? What will the doctor do? And how can I prevent kidney stones? What are kidney stones? The scientific name for kidney stones are calculi, nephrolithiasis, or urolithiasis. Stones are hard deposits made of minerals and salts in your urine, most commonly composed of calcium compounds or uric acid. Stones can form in concentrated urine when minerals crystallize and stick together. Stones can form in any part of the urinary tract. The urinary tract consists of the kidneys, the bladder, and the tubes connecting the bladder to the kidneys, which are called the ureters. Stones may be as small as a grain of rice or as large as an apple. On average, 1 in 10 people will get kidney stones in their lifetimes. Stones are more common in men compared to women, and the peak incidence of stones is in people in their 30s and 40s. There are several common risk factors to getting kidney stones, and the most common one is not drinking enough water. The fluid requirement for an adult is calculated by multiplying the body weight by 0.03 mils of water per day. As an example, the fluid requirement for a 70 kilogram adult is 2.1 liters per day. Another very common risk factor is consuming a diet rich in purine and oxalate, such as the foods shown in these pictures. We will go through this again at the end of the lecture. Having a family history of stones is also a strong risk factor, and this has something to do with the genetically inherited metabolic disorder. An obstruction in the urinary tract is also a risk factor because stasis of urine in any part of the urinary tract allows the stones to crystallize and form. Other medical conditions may also be risk factors for developing kidney stones, such as hypertension, diabetes, obesity, osteoporosis, gout, parathyroid disease, and inflammatory bowel disease. What are the symptoms of kidney stones? Pain is one of the most common symptoms that a patient can present with. The location of the pain depends on the location of the stones. Kidney stones will cause loin to groin pain, such as shown in these pictures. Bladder stones will cause lower abdominal pain and also pain on urinating. Sometimes the pain can be so severe as to cause even nausea and vomiting. Having blood in the urine, which is known as hematuria, is also a common symptom of stones. The blood may be visible, which means that the urine appears red, or the blood may be non-visible, which means that the urine appears normal, but a laboratory test will prove that there are red blood cells in the urine. Having frequency of urination and being unable to urinate are also common symptoms of bladder stones. Having a urinary tract infection is also one of the symptoms that a patient can present with. Is it possible to have stones without any symptoms? The answer is yes. Some patients may present very late because they have absolutely no symptoms. Surprisingly, a patient without symptoms can present with very large stones and even complications of stones. What should I do if I have any of these symptoms? Some patients present with emergency situations, such as a renal colic. A renal colic is a sign of urine obstruction in the ureter. This occurs when a renal stone drops from the kidney into the ureter. The stone in the ureter may or may not pass spontaneously, depending on the size of the stone. Stones larger than 5 millimeters have a low chance of passing spontaneously. If left untreated, this may cause damage to the kidney cells and kidney function. Another emergency situation is acute urinary retention. This means the sudden inability to pass urine despite having a full bladder. This is caused by urine obstruction at the bladder outlet. When this occurs, pressure is transmitted up to the kidneys, and this may adversely affect kidney function. If a patient experiences these symptoms, they should go to a nearby hospital immediately or at least on the same day. Emergency treatment is required to prevent complications. Pain relief alone is dangerous and not recommended. There are also non-emergency situations that a patient can present with, such as blood in the urine, frequency of urination, and urinary tract infection. In these situations, it is recommended that the patient see a general practitioner, or even better, make an appointment to see a urologist. What will the doctor do? In the case of a renal colic, the doctor will offer some pain relief medications, restore hydration by giving intravenous fluids, giving a muscle relaxant to facilitate passage of small stones. Stent insertion may be required for larger stones to relieve urine obstruction. A stent is a small tube which is passed from the bladder to the kidney. This tube allows passage of urine smoothly beside the stone. Sometimes immediate stone removal is also possible if the stone is near the end of the ureter. In the case of acute urinary retention, the doctor would immediately insert a urinary catheter, such as shown in the picture on the right. A urinary catheter is a small tube which is passed through the urethra into the bladder to allow passage of urine. The doctor will also prescribe some pain relief medications, and the patient will be kept for observation, the duration of which depends on the duration of the symptoms. For example, if the patient has come after more than 12 hours, they may be expected to stay overnight for observation to ensure proper hydration and correct any electrolyte imbalances. The doctor will also run some investigations to assess the general status of the patient. Common blood tests taken include a full blood count, where the white blood cell count will tell the doctor if you have a urinary tract infection. Kidney function and electrolytes will also be checked to assess the degree of damage done by the stones. Calcium and uric acid will also be taken to see if a high blood calcium or high blood uric acid is the risk factor for developing stones. Urine tests include a urinalysis, which is a general assessment of the urine. A urine culture can also be taken to identify the bacteria in cases suspected of urinary tract infection. The doctor will also order some imaging to assist in making the diagnosis of stones. An ultrasound scan is a good general assessment for the kidney and the bladder, especially if the diagnosis is not immediately obvious. However, a CT scan is the best imaging tool to assess stones. The CT scan can give accurate information about the location of stones, the number of stones, the exact shape and size of stones, as well as any complications such as swelling in the kidneys. A CT scan is essential before performing any surgical treatment for stones. The treatment for stones depends on the exact diagnosis as well as the general condition of the patient. For stones without complications, or if the patient has minimal or no symptoms, the doctor may prescribe painkillers, muscle relaxants to facilitate passage of stones, urine alkalinizers which change the pH status of stones from acidic to alkaline, fluid therapy to restore the hydration status of the patient, diet modification to facilitate dissolution of stones, and give the patient an appointment to be reassessed at a later date. If the stones are causing complications, or if the patients are acutely symptomatic, the doctor can plan a procedure to remove the stones. For kidney and ureter stones, there are two common procedures that are performed. The first, on the left, is called ESWL, which is an abbreviation for extracorporeal shockwave lithotripsy. This involves passing focused, high-frequency shock waves through the patient's body to shatter the stones. This is a procedure that is non-invasive and hence does not require anesthesia. It may be performed as a daycare procedure. Alternatively, the doctor can perform a URS or RIRS, which is an abbreviation for retrograde intrarenal surgery. This procedure involves passing a small scope through the urinary tract to locate and shatter the stones using a laser. This procedure requires general anesthesia, and the patient will be admitted for at least one night. For larger kidney stones, another option is PCNL, which is an abbreviation for percutaneous nephrolithotomy. For this procedure, the doctor will puncture the kidneys directly through the skin. A small tract will be created, giving access to a scope which can shatter the stones using a laser or an ultrasonic device. For bladder stones, the doctor can pass a scope directly into the bladder and shatter the stones using ultrasonic device or a laser or a mechanical lithotripter. For stones larger than 3 to 4 centimeters, an open surgery will need to be performed to remove the stones directly from the bladder. How can I prevent stones? The most important way is by drinking enough water. As mentioned before, the amount of water needed by an adult is equivalent to the body weight multiplied by 0.03 mils of water per day. Reducing salt intake also helps, as a diet high in sodium promotes calcium excretion through the urine. Taking a low purine and low oxalate diet is also one of the most important preventive measures. Contrary to popular belief, a normal or high calcium diet is actually a good way to prevent stones. Medications such as urine alkalinizers or citrate are especially important for patients who already have urinary stones. Some home remedies may also be helpful, such as lemon juice or coffee, but these measures alone are not enough for patients who already have stones. As promised in the beginning, these are lists of foods which are rich in purine and oxalate. Purine-rich foods include red meat, game meat such as veal, venison, and duck, seafood, organ meat, beer, and whiskey, while oxalate-rich foods are such as spinach, rhubarb, strawberries, tea, dried peas or beans, nuts and nut butters, and wheat bran. This brings us to the end of my lecture. I thank you very much for your kind attention and welcome any questions from the audience.
Thank you, Dr. Chris, for the very interesting lecture on the kidney stones. So we have a few questions from the floor. So first question from Mega Subra. Can kidney stones lead to CKD or chronic kidney disease?
Hi, very good morning, everyone. Hi. Thank you very much for inviting me for this talk. I'll go ahead and answer the question directly. Yes, kidney stones can cause chronic kidney disease if the kidney stones cause an obstruction, such as to the bladder outlet. Then the obstruction actually affects both sides of the ureters and kidneys. So this can, in the long run, cause damage to the kidney cells and also permanent damage to the kidney function. Alternatively, if there's a stone on one side, for example, in one of the ureters or one of the kidneys, the kidney damage may not be so apparent until later on because humans can actually function with one single kidney. So unless the patient already has some form of kidney damage from other diseases such as diabetes, a unilateral kidney stone disease doesn't exactly cause CKD.
Thank you for the answer, Dr. Chris. So we have our next question. So does holding my urine cause kidney stones? Actually, we come up with a lot of patients actually asking the same questions.
Yeah, well, holding the urine is actually quite similar to having a bladder outlet obstruction. The only difference is that you're doing this voluntarily. So what happens is when there is stasis of urine in your bladder, meaning that the urine stays in the bladder for a long time, this gives an opportunity for these crystals to coalesce and form stones. And in the long run, the stone gets bigger and bigger, then it will start to give trouble and symptoms.
Thank you, Dr. Chris. So next question, what lifestyle modification can we adopt to reduce the risk of kidney stone formation?
Right. So as I listed in my last slide, there are several foods and food types that should be avoided, such as the high purine foods and high oxalate foods. So as long as you consume those foods in a small or moderate amount, and you consume more than enough water for your body weight, this should be enough to reduce the risk of stones. However, just lifestyle modifications alone may not be enough, because there are other causes of stones, as I mentioned, such as metabolic disorders, which are genetically inherited. So there's nothing one can do to change that because it's already in the genetics.
All right, so come with the almost last question. How often should I schedule a follow-up, for example, for a patient who has a kidney stone? How do they actually follow up the appointments to monitor their kidney stones?
Okay, there's no general answer to this question. It all depends on the exact diagnosis. And what I mean by that is the location of the stones, the size of the stones, and if the stones are causing any complications or damage. For example, if there's an asymptomatic kidney stone that is less than 1 centimeter, not causing obstruction, then the patient does not actually have to have immediate treatment. And can be followed up even after 3 or 6 months. However, if the stone is large, for example, a 3 centimeter bladder stone, or if the stone is causing obstruction in one of the ureters or even both, then the patient would require immediate treatment.
Thank you for the answer, Dr. Chris. So next question from the floor, why does some kidney stone cause infection and some do not?
Well, most kidney stones actually harbor some bacteria inside them, and they will cause infections, especially in patients who have immunodeficiency, which is the result of common diseases like diabetes. And diabetes is very prevalent in Malaysia. So in a young, healthy adult, the chance of having an infection from a kidney stone is lower than compared to the elderly patient with diabetes.
Thank you for the answer, Dr. Chris. I think that will be the last answer for the Q&A session. Thank you, Dr. Chris, again for being one of our speakers. Thank you for the good talk as well.
Thank you. It was my pleasure. Enjoy
you.
the rest of the webinar.
You too. All right, so coming to the last lectures for our plenary 2 before our break. So we have a topics. Next one is Seeing Red, a simple guide to deal with blood in your urine. It's very an interesting topic. It's quite common for our urology patient. So we have our esteemed speaker. Very greatly honored to invite Dr. Muhammad Najib Aziz, consultant urologist from Hospital Selayang. So without further ado, we invite Dr. Najib for the next lecture. Thank you.
Hello, good morning. My name is Muhammad Najib Aziz. I currently work as a urologist at Hospital Selayang. First and foremost, I would like to thank the Urology Unit Department of Surgery UMMC for inviting me as a speaker for today. And basically, I'm going to talk about hematuria, so seeing red. I'm going to give some simple guide to deal with the blood in the urine. So basically, a very simple topic, but frequently being mismanaged. So hematuria is one of the most common urological problems, about 20% of urology evaluation. And among healthy volunteers, it's been reported that the prevalence range between 2 to 31%. Hematuria can be divided into non-visible and visible hematuria. Non-visible hematuria can be defined as more than 3 red blood cells per high profile from microscopic analysis. Dipstick hematuria is considered significant if it's 1 plus or more, but trace hematuria is considered negative. So false positive dipstick can happen, and it can be due to myoglobinuria or provident contamination. In normal people, there are few RBCs can be found in urine. According to 2 old studies, about 70% of people with non-visible hematuria, there is no abnormalities found despite thorough investigations. There are a few other transient causes of the microscopic hematuria which may occur after rigorous exercise, sexual intercourse, or menstruation. But having said that, any case of hematuria, be it non-visible or visible hematuria, I would definitely evaluate it further. So what is considered significant hematuria? It can be any single episode of visible hematuria. It can be any single episode of symptomatic non-visible hematuria in the absence of UTI or other transient cause. Or it can refer to persistent asymptomatic non-visible hematuria. So all the cases, it should be referred to urology for further workup. The causes of hematuria, as you might all know, so top of the list is malignancy. Other causes like stones, infections, inflammation, trauma, or other benign causes of glomerular disease, BPH, renal cyst, coagulation problem. There are a few other drugs also can cause hematuria. So as for cancer, they observed about 3,500 patients and found out about the rate of cancer detection in non-visible hematuria was about 3.1%. But the rate is higher in visible hematuria, where it's reported about 13%. Another later study showed that non-visible hematuria, the rate of cancer detection was about 5 to 10%. And in visible hematuria, the rate doubled to 20 to 25%. So in a standard urology setting, we do a systematic evaluation. So in the history, we always look at the risk factors for malignancy, how many packs they smoke, how many years they smoke. You need to know about their current or past occupations, because you want to know whether they are exposed to any benzene chemicals or aromatic amines. For example, whether they work in rubber factory, whether they had contact with petrochemicals, whether they work as hairdresser as well. And you should inquire also whether they have any family history of urological cancer. So as for the focus urological examination, I will probably look at any abdominal or suprapubic mass, whether the kidneys are bloatable, and do digital rectal examination to feel for the prostate cancer. One key point is that any patient who comes with hematuria on his own antiplatelet or anticoagulants, so do not always assume that the hematuria is caused by all these medications, even though they are diagnosed as over-warfarizations. So in this case, I would definitely go for a thorough investigation, similar to those who don't take any antiplatelet or anticoagulants. As for the laboratory investigation standards, we send FBC, coagulation profile, renal profile, and PSA as well. We send the urine to rule out UTI. As for the urine cytology, it's not necessary in the initial assessments. Usually it is done for those bladder cancer who had done TURBT on surveillance. Sometimes also urine cytology can be done in persistent non-visible hematuria. So what are the imagings that we do? So for example, if the patient comes with hematuria and complain about line to groin pain and suspect stone disease, so you probably want to do a KUB X-ray, ultrasound, and CTU. So generally speaking, for the ultrasound, you look at the renal parenchymal disease, any renal lesions, any bladder growth inside, any hydronephrosis, any renal cyst, and any prostate enlargement. In any case of visible hematuria, I will probably do a CT renal phase as my first choice investigations. I will probably say that, okay, don't waste time by doing ultrasound first, because definitely in visible hematuria, you always find some pathology in that. Another minimal invasive procedure we can do in our setting is flexible cystoscopy. So I want to ask you all, do all patients need all these investigations? There is no doubt that in visible hematuria, you have to do flexible cystoscopy and contrasted CT scan. But for non-visible hematuria, do you want to unnecessarily pose radiation risks and also do some invasive procedure to the patients? Keep in mind that my previous talk about 2 old studies say that the rate of cancer detection about 5 to 10% in non-visible hematuria. So is it worth it to do everything for non-visible hematuria? So there should be one strategy which has more personalized approach rather than one size fits all approach. So that is why American Urological Association Guideline 2020 has established a risk stratification system which stratified patients into low, intermediate, and high risk. So there are 4 criteria in this system. First of all is age, whether they are woman or man, whether they smoke, how many RBCs per high power field, and whether they have any risk factors for uterine cancer. And they reported that the associated risk of malignancy for low risk patients about 0.2%, for intermediate is 1.6%, but for the high risk about 11.1% respectively. So after you evaluate from history, physical examination, all the blood tests, so you stratify this patient according to the system, and you decide what to do next with them. Right? As for the low risk, it's a shared decision making between you and the patient. Either you want to observe first by repeating ureaphamine in 6 months' time, or if the patient is anxious, or they want to know more about their diagnosis, you can offer cystoscopy and ultrasound KUB. As for intermediate group, you do cystoscopy and ultrasound, but definitely for high-risk patients, you should do a contrasted CT scan and cystoscopy. Alright, so if you do all the investigations in non-visible hematuria that you cannot find anything, any pathology, is there any risk of subsequent urological cancer developing? So according to these old studies, over the 10 to 13 years of follow-up, they revealed that where initial investigation in these patients are negative, and then after that they repeated again the urinolysis, which showed no hematuria, they found out that there is no patient developed urological cancer. So how about after initial negative workup? How do we follow up these patients? So according to AUA 2020, should repeat the ureaphamine in 12 months time. If it's negative, you can stop follow-up, reassure the patients that the risk of developing urological cancer is the same like the normal population without any microscopic hematuria. If non-visible hematuria persists after initial negative workup, should we repeat all investigation? So according to the AUA as well, so the diagnostic yield of repeat investigation is very low. So they recommended that the repeat investigation is not necessary unless the patient becomes symptomatic or develops visible hematuria. Okay, I would like to share a few cases with you as to show you varieties of hematuria causes. So for example, for this case 1, 64 years old lady with diabetes, she's been treated many times at UTI by the GP with complaint of dysuria microscopic hematuria. After bouts of antibiotics and the system persists, she was finally referred to urology, and we did cystoscopy which showed velvety red patches over some areas of the bladder wall. We took biopsy and it shows bladder carcinoma in situ. So there are a few key points in this case that 1, bladder CIS is pre-malignant condition, and the symptoms is always dysuria and microscopic hematuria, and as such it can mimic UTI. So always bear in mind this and refer to us. Second, it can appear as flat erythematous lesion in the bladder from cystoscopy, and it won't reveal itself from the CT scans, either ultrasounds or CT scans, right? So second case, I have a young chap, 44 years old male with newly diagnosed hypertension. He was referred for persistent asymptomatic non-visible hematuria. He doesn't smoke. There is no risk factors for malignancy. Examination is normal. There's no UTI. The ultrasound is normal. The creatinine is normal. It's just that the ureaphamine showed 2 to 3 plus blood on 2 readings. So the urology MO plan for flexible cystoscopy, and I happened to be there and overheard the conversations. And further history revealed that he has generalized edema, which the KKMO gave Lasix. I look at the ureaphamine in detail. It showed protein 2 plus on 2 readings. So okay, my thinking is that this could be a glomerular disease rather than urological causes. So my plan was to refer nephrology for further workup, and I would probably repeat the ureaphamine in 3 to 6 months time with KIV, do a cystoscopy for him. Third case, a young lady who was referred for persistent asymptomatic non-visible hematuria with possible diagnosis of bladder stone from KUB X-ray. My first thinking, no symptoms, young lady, has bladder stones, is very unlikely unless she has a neurogenic bladder. So I look at the X-ray myself. That was not a bladder stone. So typically it was rather a calcified uterine fibroid. But I did flexible cystoscopy anyway because the patient was quite anxious and it was normal. So my plan was to refer to gynecology and discharge urology. Final case, about almost similar case, a 72 years old male, also same, non-visible hematuria, diagnosis of bladder stones. Okay, so in urology clinic, I asked him, he doesn't have any symptoms except low back pains. So I saw the x-ray. This part is not a bladder stones. This was typical of flablate. It is small round calcium deposit in vessel, and it is usually located peripherally within pelvis. So given the history of back pain, back in my mind, always entertain the diagnosis of prostate cancer in elderly. So put my finger inside the anus, check the prostate. It was very hard and craggy. Took the PSA, it was 1000. So what I want to show in this case is that from a referral of microscopic hematuria to a diagnosis of metastatic prostate cancer. So be aware of that. Alright, thank you very much for your attention. Please ask me if you have any inquiries. I would very happy to answer it. Thank you so much.
All right, thank you, Dr. Najib, for the interesting talk on hematuria or blood in the urine. So we have a questions from the floor. Dr. Najib, are you around?
Hello, can you hear me?
I can't see you, but I can hear you.
Yeah, I'm not sure why.
Maybe the background, I think. Maybe you can just turn off the background, I guess.
Yeah, just give me a moment. Sorry.
All right.
All right.
All right, yes.
Sorry about that.
No worries. Okay, so we just get to the first question. So from Mega Subra, how strenuous exercise can lead to hematuria? Actually, this question has come out from a lot of our patients actually come to us. So can you just give your opinion on that?
All right, good questions. I think nobody knows. While I read a lot of articles, it just mentioned strenuous exercises, but it didn't mention in particular how strenuous is it and how it happens. He just found out the association between the exercises and the non-visible hematuria. So that's all I can say.
I think I will agree with that. So the next question, how long should I monitor the presence of blood in my urine before seeking medical attention?
Okay, so I think my first few slides I mentioned that after two or three readings of asymptomatic microscopic hematuria, then you can request to be seen by urologists for further evaluations. But of course, if you do have a visible hematuria, then definitely you should need to be seen as urgent as possible.
Thank you for the answer, Dr. Najib. So the next question, is it safe to wait for the result of the diagnostic test for a patient who came with a hematuria, or they should have started the treatment immediately?
Well, definitely in public settings, from experience, it's going to take a long time to do all the imagings and any procedures like flexible cystoscopy. I myself, if I look at a patient, assess the risk factors. If I think that he's at high risk, the patient is very anxious, I'll probably do the flexible cystoscopy on the same day of clinic itself. At least we do something to the patient rather than go back and come back later, wait for a few months later, and which I don't think is appropriate, right? In terms of getting the imagings, well, I can't help with the in the government setting because I understandably there's a lot of patients needing scans and the waiting time is long. But in my opinion, if I think it is really urgent, I'll talk to my radiologist myself and to get the urgent investigations. So it all depends on what the risk factors do you have, how bad it is, and then from there we can, do the necessary steps, to expedite things.
Yeah, totally agree with that. It actually depends on the limitation of our services as well. So the next question from Thomas Vani. When is urine cytology deemed relevant to be taken in non-visible hematuria?
Okay. As a first investigation, don't think it's necessary. All right. There are many false positive and negative results, and then it won't really tell you what are the what are the causes actually. So it depends on what setting you're gonna do the urine cytology. For example, in urology, patients who had bladder cancer and already diagnosed and you want to go for surveillance, and urine cytology is part of the surveillance and investigations depending on the tumor itself. But generally speaking, those patients who don't have any cancer or it's been under follow-up for non-visible hematuria, I think it's worthwhile to do maybe at least one after all the investigation is negative, right? But having said that, if it's negative, it doesn't mean that, okay, you're 100%, you don't have any uterine cancer. You can still have, because bear in mind that urocytology has, it's not really sensitive picking up low-grade cancer. Those high-grade cancer, yes, the result will be positive, but any small, tiny, like low-grade tumor, the result will be negative anyway. So basically, don't solely depend on urine cytology.
Thank you for the very precise answer, Dr. Najib. I think that should be the last questions from this Q&A session. So thank you, Dr. Najib, again for being one of our speakers. Very interesting talk and very eye-opening regarding the hematuria.
All right, thank you so much.
Okay, thank you. All right, so we have come to our an end of the plenary 2. So we're having our short break for next plenary. So we're back at 12 p.m. in about 1 hour time. So please kindly re-log in again using the same link, and we'll see you guys back at 12 p.m. So just a housekeeping rules, if there's any questions that you guys want to ask, just put in the chat box or at the Q&A buttons. Thank you so much.
Hi, Mr. Teo.
Hey, hi, Jeffrey. Can you hear me?
Yeah, I can hear you loud and clear, Mr. Teo.
Okay, I can't see myself.
Yeah, I can see you as well. Yep.
Okay. How do we sort this out?
Are you on the phone or you're on the laptop, Mr. Teo?
I'm on the laptop.
Okay, all right. You can see on your left bottom, there is a video button as well as a mute button. Maybe you want to click on both the buttons, Mr.
Yeah,
Teo?
both are on already.
Oh, okay. Both are on. Maybe you want to off it and on it again, the video part, Mr. Teo?
Okay, I just did that.
That nothing coming out. Wait, I get my IT team to guide you.
Okay, sure.
Hi, Dr. Jeffrey. Hi, Dr. Teo.
Hi.
Okay, this might be a little bit of a hardware issue. You can't switch it on.
Sorry, I can't hear you. You're quite soft. Let me just increase the volume. No, I'm on maximum.
Okay, Dr. Teo, can you switch off your video first?
Okay, video is off.
Okay, can you go to your video setting? You go to the start video, there's an arrow pointing down. Can you click on the arrow?
Sorry, which one? Start video. Okay, the arrow. All right.
Okay, click on the arrow, go to video set. No, not yet. Can you see what camera is selected?
Video setting HP Full Vision Full HD. That's my laptop.
Okay. Okay, so it selected your laptop video. Can you click? Are there any other options?
No, no other options.
Okay. Okay. Can you maybe is your HD video switched on?
HD video switched on. I mean, it's a laptop. I don't even know how to switch it on.
Okay, in the video setting, you can see your camera, right? It would say either integrated camera or whichever.
Okay.
Does it say integrated camera?
No, no. Do you want me to share my screen? Then you can.
No, it's not necessary.
Okay.
Okay, so you under camera, what does it say again?
HP True Vision Full HD.
Okay. Okay. Can you okay, can you try and switch on your camera again?
Okay, I just did that.
Okay. Should switch on. Let's see. There's nothing blocking your camera, right? It doesn't have the shutter.
No, no.
Okay. Can you click alternate end?
Alternate?
Alternate end.
Like in Nigeria.
Yes, correct.
Okay, I just did that.
Okay, still no one.
End. No.
the only other solution that I can think of for this is if you log out and then you come back in.
Okay, sure, I'll try that. Okay, I'm back.
Okay. Oh no, you still don't have your video.
No, still no video.
Is it a built-in camera?
Yeah, it is.
Oh. I'm not sure I can help with this one without being there. Let's
I put in an external speaker. I shouldn't think that would be a problem.
Yeah, it shouldn't be a problem.
I unplugged my external speaker already.
Okay. Yeah, sometimes it could be the computer itself. Maybe it is overwhelmed, like the use of the RAM is almost fully utilized. Sometimes it can cut off the camera.
Yeah, okay.
Yeah. Okay. If you click the start video.
Okay, wait, hang on. Let me try with my iPad then.
Okay, sure. Yes.
Yeah, I'll just leave now. I'll come back in again. All right. Bye. Okay.
Yes, now we can see you.
Okay, yeah. Okay. Now, how do I put in the virtual background you all request, you all send?
Okay, you will have to go to the settings. I think it's the top right corner. There would be the 3 dots, and you can choose your virtual background from there. But you have to have your virtual background on your iPad as well.
Okay, let me just get that now.
It's okay, Mr. Teo. We can drop it in the chat box, so you can download it straight from your Zoom chat box.
Okay. Where is?
Wait, Mr. Teo, let me drop the file into the Dropbox.
Okay.
Into the chat box, yeah, so that you can straight away download it. One moment.
Okay,
Yes,
just
Mr.
hang
Teo?
on now. Just come back.
Okay, let's go.
Okay, I'm back. Chat box is Q&A, is it?
No, the chat. Mr. Teo, chat.
I'm not used to using my. Okay, right, chat. Fine. Okay, I don't have anything in my chat yet. You sent already, Jeffrey?
Yeah, actually I sent already. Adelina, can you assist Mr. Teo in that?
Yes, can. I just have a question. Dr. Teo, is your phone an iPhone?
No, my phone's Android.
Okay. All right. Let's see. It should be in the chat. Dr. Jeffrey has put it in. Never mind. Maybe we'll try and I'll send it directly to you.
Hi, Dr. Teo, Shuada here.
Yeah,
Because
hi, Shuada.
I'm using iPad as well. So what the next step you can do, because from iPad I can't even see the picture, the one that Dr. Jeffrey put on chat box. So what you can do, you can just press on the triple buttons there. You go to backgrounds and effects,
Okay.
and then you just press plus at the backgrounds there, just on top of the background. There's a plus button.
Okay. Yeah.
Then you add the picture there.
Okay. I have to go and find it. Okay. I haven't downloaded it from the email yet.
Oh, okay.
Okay, so I just have to do that quickly. Wait, just let me.
No worries. Dr. Teo, you are overseas, right?
No, I'm back in Penang just for a short while. I came
Okay.
back just for today. How do I get up now?
There's a small arrow on the top left hand side.
Yeah, but it's not working. Okay, never mind. Just go into my email. Okay, I'm back.
Alright, Dr. Teo. Yeah, we can see you with the background. All right, good afternoon, everybody. So welcome back to our virtual urology webinar for second part of the day. We would like to everyone to re-log in for the second part, which is a plenary 3. I'm Dr. Shuhada again from the Urology UMMC. So without further ado, we'll start with the first lecture of the plenary 3, with the topic of nighttime bladder blues, unraveling the mystery of frequent urination. It's our great pleasure to invite our next speaker, Dr. Teo Boon Wei, consultant urologist from Penang Adventist Hospital. He's completed his fellowship in urology in Melbourne, Australia. So without further ado, we invite Dr. Teo for his next lecture. Thank you.
Good afternoon, everyone. First and foremost, I'd like to thank the organizers for inviting me to give this talk. The topic I've been given is entitled Nighttime Bladder Blues, Unraveling the Mystery of Frequent Urination. Basically, I'll be talking about nocturia. So, nocturia refers to the act of waking up at night to urinate. By definition, it means one or more voids at night, but there must be a period of sleep that must precede or follow it. So that means if you pee before you go to sleep, that doesn't count as nocturia. Or if you pee when you're waking up in the morning, it doesn't count as well, unless you wake up because you need to pee. It is the most bothersome and most common of all urinary symptoms. We must differentiate this from nocturnal enuresis, where there is an unaware and involuntary void while in bed. And again, you must differentiate from convenience void, where one wakes up for any other reason than the need to urinate. For example, say inability to sleep and waking up and then deciding to go and wee. The impact of nocturia affects overall health and daytime functioning. There are risks of falls and injuries when you wake up at night. It has been found that 25% of all falls happen at night when the elderly wakes to go to wee. Can you imagine that waking up in the middle of the night when you're groggy, where there are no lights, going to a bathroom which is slippery? This is a recipe for disaster. Nocturia also reduces the quality of life and reduces productivity. And it also affects the health of the partner. You know, when they share the room or share the bed. That's why some elderly couples sleep separately. Of course, nocturia waking up at night will cause sleep deprivation. This sleep deprivation, we know, can cause exhaustion, mood changes, tiredness, fatigue, lethargy, inattentiveness, and cognitive dysfunction. About 40% of people have trouble going back to sleep, and this nocturia is associated with decreased physical health, obesity, diabetes, depression, heart disease. Now we talk about nocturia in numbers. This is based on a study done in 2020 by Professor Ong Teng Ek from UMMC itself. From their studies, they found that 57.3% prevalence among Malaysian adults and 37.3% face sleeping difficulty half the time or more after waking up. So they find it difficult to go back to sleep. If it's 2 or more voids a night, the people who were asked, they found it is more bothersome than just 1 void a night. Actually, 56.7% are not aware there is even a medical condition. And Only a quarter sought medical attention. The issues with nocturia is that it is underreported, it's poorly managed, and it's inadequately treated. Patients, on the patient side, is maybe because they are reluctant or embarrassed to complain, or some may believe it is normal part of aging. On the part of physicians, the initial treatment tend to be superficial and routine. So for most men, they'll be treated for BPH, that's benign prostatic hyperplasia, which is the overgrowth of the prostate tissue as the men age. And for women, they tend to be treated just as an overactive bladder. But patients need further evaluation, and management is lacking in this issue. It takes about 1 to 2 years before the onset of symptoms before a patient gets effective treatment. So the objective of my talk is to help improve the diagnosis and treatment. And hopefully listeners can learn some simple self-evaluation and identify the causes that lead to nocturia, and then maybe lead to a better treatment outcome when they seek medical treatment. And hopefully there will be substantial symptom resolution and improvement of quality of life. There are 4 basic conditions that lead to nocturia. The most common is nocturnal polyuria. In this, there is a nighttime overproduction of urine, as in when a person has heart failure or have some hormone disorders. Then there's global polyuria, where there's a high 24-hour urine volume, as in diabetes. So the first one is only in the nighttime. The second one, global polyuria, is day and night as well. Then bladder storage dysfunction is another condition that leads to nocturia, as in an overactive bladder, or if the patient has prostate problems. Then there is sleep disorders like sleep apnea. So I'll go into them one by one. We'll start with the most common, which is the nocturnal polyuria, which makes up 88% of the causes. The definition as given by the International Continence Society. Yes, there is a society for continence. Their definition is that there is a nighttime urinary production more than 20% of the total 24-hour urine volume, if it's for a younger adult. And for older individuals, more than 33% of the pee you give at night after you sleep over the 24 hours during the day. So the maths is that you calculate the urinary volume from nocturia, waking up at night to pee, versus the urine volume over 24 hours. You minus that by 100 and get that percentage. There is a proportional decrease in daytime urine production in this kind of situation, because most of it is done at night, so there's less during the day. Another definition will be a nighttime urinary production of more than 90 mils an hour, or 6.4 mils per kilo body weight. This nocturnal polyuria is more prevalent in older patients, and contributing factors are caffeine, excessive evening oral fluid intake, and alcoholism. It's associated with congestive heart failure, obstructive sleep apnea, evening use of diuretics. Diuretics are medication. It's given to patients with, for example, heart problems, so that they don't overload in fluids. And patients with have peripheral edema. This refers to swelling of usually the lower limbs, the legs, due to fluid accumulation. And it's also associated with high dietary salt intake. There are hormones that are related to nocturnal polyuria. There are 2 of them. The first one is this arginine vasopressin, in short AVP. This is an antidiuretic. What antidiuretic means is that, like I said earlier, diuresis is to make urine. So antidiuretic is to stop making urine. And this is produced by parts of the brain. It is released when the blood concentration is high. So blood is thick, and there's high sodium content. And when the blood pressure is low. This is the body's mechanism to preserve itself. So it reduces the urine volume. So it preserves the volume, but then the urine that's given out is higher in concentration. Also, to preserve oneself, there is constriction of smaller blood vessels, and this will also increase the blood pressure. This AVP is naturally increased during sleep. And this is part of the normal circadian rhythm. Circadian rhythm is basically the body clock. So the body knows that when it's nighttime, it's time to sleep, it will produce the AVP. So actually we produce less urine at night than during the day. But this natural circadian rhythm and production of AVP is diminished or even disappear when they're in the elderly, patients with Parkinson's disease, patients with some AVP receptor mutations, some kidney disease, electrolyte abnormalities, heart problems, sleep problems, drug usage, and some venous insufficiency, meaning some blood flow problem of the lower limbs resulting in swelling of the legs. The other hormones, the other hormone that is related to nocturnal polyuria is atrial natriuretic peptide. This on the reverse side is a diuretic. That means it causes us to produce more urine, and it's produced by cardiac muscles in the atria, which is one of the chambers in the heart. There are volume receptors in the atria. So when there's increased fluid, this chamber of the heart is stretched and it releases ANP. The purpose of ANP is to reduce blood pressure and then also reduce the total blood volume. It increases the kidney sodium excretion, which acts as a diuretic to draw water out. So when there's increased ANP secretion, it is found when there's excessive fluid in the conditions where patients have congestive heart failure, or they're uncontrolled hypertension, or they have obstructive sleep apnea. The second cause of nocturia is global polyuria. So the previous one is nighttime. Global polyuria is throughout the day. So the definition is continuous urinary overproduction throughout the day. So by calculation, it will be a urine output more than 40 mL per kilo for every 24 hours, or the daily urine volume more than 3 liters. It's associated with increased fluid intake caused by hypercalcemia, drugs taken. Primary polydipsia is just drinking a lot of water, more than it is required. Diabetes mellitus or diabetes insipidus. Then the third is bladder storage problems. In bladder storage problems, there is no polyuria. The amount of urine output is not more, it's normal. But then it is just that the patients complain of having to wake up at night. So the wee at night wakes them up. The bladder storage problem, it could be because of a reduced bladder capacity, or it could be because the bladder muscle is overactive, or it could be as a result of a sleep disorder. Patients will have multiple frequent voidings at night with only small urinary volumes, and 50% of them will have daytime urinary urgency as well, and they may have other urinary symptoms. Bladder storage problems are caused or aggravated by a number of things. Caffeine and alcohol intake can stimulate the bladder and cause one to pee very, very frequently. Diuretics, medication to cause one to pee, obviously can cause one to pee more often. If one has bladder stones, if they have an enlarged prostate, if they have a neurogenic bladder, that means a bladder that is injured and there is some nerve damage, where a patient has decompensated this detrusor. Detrusor is the bladder muscle. So it is the bladder muscle that is damaged already. Atrophic vaginitis happens as women go into menopause. Prolapse of the vagina or the uterus. Peripheral edema is swelling of the lower limbs, lower extremity due to fluid retention. Urinary infections can also cause bladder storage problems. Anxiety, when you're anxious, you're scared, now you want to pee very often. You can get also non-infectious bladder inflammation called cystitis, for example, due to radiation. You can pee more often because your bladder is smaller, as a result of surgery or radiation for, say, cancer cervix, And then if one has had a bladder catheterized, that means on a tube to pass urine for a prolonged time, the bladder can also reduce in volume. The last that causes nocturia is sleep disorders. So sleep disorders can be insomnia, inability to sleep, or obstructive sleep apnea, where there is obstruction in the airflow, and then the patient cannot breathe and then wakes up at night. This can be suspected if the patient is unable to return to sleep after they wake up to pee, or in the morning they have morning fatigue. The nocturnal urinary frequency is the side effect actually of the sleep disorder, and it is not the cause. 50% of patients in OSA have nocturia, and this is due to the effect of ANP, atrial natriuretic peptide, which I mentioned earlier in nocturnal polyuria. A combination of snoring and significant nocturia. So you look at, for all the listeners out there, if you are one of them, this is a strong predictive factor of obstructive sleep apnea with a sensitivity of 97.4%. To know whether you have obstructive sleep apnea, you can answer a simple questionnaire which you can get off Google. And one of the examples is this questionnaire called the Stop Bang questionnaire. Other causes or contributing factors to nocturia could be peripheral edema. So, like I said a few times already, edema is swelling due to fluid accumulation, peripheral usually in the lower limbs because we spend most of our time standing and sitting. So at the end of the day, when we lie down, the extra fluid that is collected in the lower limbs shift back into our blood circulation, into the intravascular space, and then the kidneys will take that fluid and excrete, and that's why we wake up at night to pee. Drinking large amounts of fluid before bedtime is not a good idea because it can contribute to nocturia, as well as ingesting caffeinated drink or alcoholic drinks. Congestive heart failure, kidney disease like nephrotic syndrome, obesity, high blood pressure, liver failure, depression, taking antidepressants, Parkinson's disease, being pregnant, those are contributing factors to nocturia as well. So when you see a doctor, what they do, they first take a history. They want to find out what is your sleeping habit, your drinking habit, how much sodium you take, whether you have medical illness like diabetes, hypertension, whether you're taking antidiuretics, again, the tablets to help you pee, whether you have any urinary symptoms, how many times you wake up at night, and how much your sleep is bothered. Then they do a quick physical examination. Usually we'll check the blood pressure. We look at the heart and lungs to see whether there's any fluid overload. We see whether the bladder is distended in the abdomen. And then sometimes if we have the facility, we'll do a bladder scan to see how much residual urine is left after a person pees. If we don't have that, a more uncomfortable way is to actually pass a catheter into the bladder to see how much urine is left after urination. We also do a rectal examination to feel the prostate, to see whether there are any masses, whether they're in the rectum, whether the tumors, or maybe it's just fecal loading. Then we check for any neurological abnormalities, anything wrong neurologically, and then we look for the lower limb swelling. Then we send tests. We want to look at whether somebody has diabetes, check their kidney function, check their electrolytes, and then look at the urine to see whether it's concentrated or not, and see if there's any infection or any blood in the urine or anything abnormal in the urine. The most important investigation on top of more than any test that we can do is actually this voiding diary. This is key to evaluating nocturia. So the person who's suffering from nocturia is asked to record the time and amount of urine they void over a full 24 hours. 3 consecutive days would be best, but even a single 24-hour diary is helpful, provided it's accurate. You'll be surprised how difficult it is to get a good voiding diary. If we can also record the timing, amount, and also the type of fluid ingested over that 24-hour period is also helpful. The usefulness is well established. There's without doubt, but only 37% of patients who actually complain of nocturia ever fills one out. The desire to do a scope into the bladder, do a urodynamic study, which are very complicated urological tests, are not actually necessary or recommended. This is an example of voiding diary. So as you can see, day 1, you separate it into the day and the night. At night, you record when you wake up at night, and we chart how much. We ask the sufferer to chart how much they drink and also how much they pee. So there are some treatment and management misconceptions. People sometimes don't seek treatment because they think it's unnecessary because they're not bothered. But actually, only when they are treated, then they realize that actually it was actually bothering them and they didn't realize it that much. And it's also easier to treat when it's early. And some people think, oh, nocturia is part of aging. Some believe it's untreatable, so they don't seek for treatment. So people tend to underestimate the bother and the damage to sleep quality, the general health, and their daily activities and quality of life. So the initial treatment we would tell the patients is to set a reasonable goal. Don't aim too high. If you pee 4 times, if you can reduce that by half, that would be good enough. Or if it's more, maybe 1 or 2 voids a night would be a fair goal to set, rather than to aim for not to pee at all while after going to sleep. It's important to prepare for bed 20 to 30 minutes before bedtime by doing some relaxing protocol. For example, listening to soothing music, meditation, having a warm bath, those kind of things. We encourage patients to limit the fluid intake in the late afternoon and evening, especially between dinner and bedtime, and definitely no fluids 2 hours before bed. During the day, they are encouraged not to drink more than 2 liters a day, and then to reduce salt intake and protein intake. And if they are taking diuretics, they are encouraged to take it in the afternoon. Usually, some people take it in the morning. So when they take it in the morning, they pee in the afternoon, and then in the evening until they sleep, the fluid reaccumulates, and then they'll pee when they are actually sleeping. So in the afternoon is the best time to take the diuretics. If patients have lower limb swelling, they are encouraged to raise their legs so that all the fluids return after dinner, or even use compression stockings to help the patient to hold their urine until they get to the toilet. They are taught Kegels exercise, pelvic floor muscle exercises. A regular physical activity in the afternoon, not too late, not too near the bedtime. In the afternoon will be good. Of course, again, I say to limit alcohol and caffeinated beverages. And then remember, this is part of bed hygiene, where bed is only for sleeping or sexual activity. We shouldn't associate the bed with work or reading a book, so that it's easier to go to sleep. And if one is unable to sleep, then don't keep on tossing and turning, but get up, perform some relaxing activity before returning to bed. Of course, establish a regular sleep routine. Get your body clock into a rhythm, so same time every day, go to sleep. And this is a common problem these days, and that is to minimize electronic usage. So handphones, computers, television, the bright lights from these devices will cause you to be more awake, and you'll find it harder to sleep. Optimize the bedroom environment. Acoustics, make it quiet, have blackout blinds if you have to sleep in a daytime, and then have set the temperature so that it's cool to sleep. Avoid afternoon naps, obviously, because then you won't feel sleepy. Avoid smoking after dinner, and avoid serious thoughts on issues and problems just before going to bed. For those who wake up at night to go to the toilet, and those who have the problem of nocturia, we must remember not to overly limit the fluid intake, because dehydration can be the other problem. If there's mobility issues, a bedside commode or even a urinal will be useful. If you're actually going to the toilet, consider night lights so that you can see where you're going. And if you happen to have accidents, then mattress cover, absorbent grease, and pads will make cleaning up easier. Then there are also behavioral therapy. Again, we talk about pelvic floor exercises to strengthen the continence, to hold the urine. And one is taught, patients are taught urge suppression techniques. So if you feel like to be distracted by doing something like a crossword or finishing an episode of a show, or maybe trying to sit down and try to distract yourself from the urge to pee. If you feel like peeing, a patient is encouraged to delay the voiding. Then, of course, we mentioned about fluid management, sleep hygiene, I mentioned, and also peripheral edema management. If all this fails, then you see the doctor, and there are a number of medications they give. They adjust your diuretics, give you medication if they think you have prostate issues, maybe even give you some medication to increase your bladder capacity. Then there are other things that you can give for ladies and the injections and all. One mention about one medication is desmopressin. This is a analog of vasopressin. So this is given to reduce the urine output. But in the flip side, you get more urine in the day. But one danger is that it can cause hyponatremia in high-risk groups, as mentioned in the slide. So it's likely to develop in the first week. So usually we follow up very early after a patient is started on the medication. It is very important because left untreated, it can cause serious complications like seizure, coma, respiratory depression, or death. So we tend to give the lowest effective dose, but men tend to take higher doses. It comes in two forms, in oral or nasal spray. The nasal spray has a more consistent effect and also is more safe. There are other remedies you may have heard of, but they are of uncertain value. Finally, we come to a conclusion. So nocturnal polyuria is the most common of nocturias, but mixed causes are also very common. There are no specific cure for nocturia, and proper evaluation is important, with emphasis on avoiding diarrhea. Simple behavior and lifestyle measures is as effective, or sometimes even more, than medication. Thank you for your attention.
All right, thank you, Dr. Teo, for the very interesting and very informative talk about nocturnal polyuria and in specific nocturia itself. It's very good explanation in terms of all the details that patients usually come to us asking what can be done and what was the causes of their symptoms. Mainly have to wake up at night to pass urine. So we have a few questions on the floor. So basically, can this nocturia be cured, or is it a chronic condition that requires ongoing treatment or management?
First and foremost, thank you once again, for organizing this very useful talk for the public and inviting me to speak. That question is a bit difficult to answer unless we know actually what is the problem. So I think rather than to say that it is incurable, I think it is more important to find out what is the cause. So for the person who's asking that, I would say that seek a doctor, if not a general practitioner, then a urologist, to figure out what's going on.
No, I agree with that also, Dr. Teo. So the next question is, how many times per night waking to urinate is considered normal? And when does it become a concern?
All right. As you can see, when you're young, if you remember, you don't wake up at night to pee. So when you say nocturia, that means you wake up. So if you even wake up once at night, by definition, that is nocturia. But people find that it is. Studies have shown that if you wake up 2 or more times, that is more bothersome. So that would be the time where you would consider seeking treatment.
So we have another question. Is there any evidence to support use of herbal medicine or any alternative remedies for nocturia that you know of, Dr. Teo?
Like I said, there are a lot of things that have been looked at, but these things have not been conclusively proven to be useful. So what I've mentioned are those that have been adequately tested and checked before it is recommended. Yeah, but there will be, as with any condition, there'll be a lot of recommendations by friends and people who have personal experience. But these are all very uncertain.
Understood, Dr. Teo. So we have a question here. Is cold temperature associated with nocturia? I think this one is quite a common question from our patients.
Well, the thing is that when it's cold, we sweat less, and that's why we have more fluid that is accumulated in the body that comes in the form of urination. If you are in a warm condition and you're sweating, or if you are working in a warm environment, then you would sweat more, and then you have less pee. So yeah, if it's a cold condition, they tend to have more urination.
And the next question is examples of foods or beverages that can induce nocturia apart from caffeine.
Caffeine is the most common. Just to stress on this, people think caffeine means coffee, but tea as well. Soft drinks is also has caffeine. For those who are unaware, there are certain soft drinks like Coca-Cola, Pepsi, and then people who take energy drinks like Red Bull. Red Bull is very high in caffeine. All right. Other drinks, of course, there are alcohol. So different types of alcoholic beverages. Those are the common causes.
Totally agree with that, Dr. Teo. I think if there is no more questions from the floor, I think that will be the end for Dr. Teo talk. Thank you, Dr. Teo, for joining us. It will be great honors from Urology UMMC to have you as one of our speakers. Thank you so much.
Thank you again.
Thank you. All right, so we move on to our last topic of the day. So it's a very interesting topic. It's a new topic that we introduced this year, which we don't have this topic actually last year. So it's a new topic. So it's called Drenched Sheets, Understanding the Causes Behind Your Child's Nighttime Bedwetting. So we have our great speaker from Hospital Consulate Tengku Mukris UKM, Dr. Lim Lee, is a consultant urologist, completed his fellowship in pediatric urology from Taiwan. So without further ado, we'll have Dr. Lim for her lecture.
Hi, good afternoon, everyone. I'm Lim from Hospital UKM. So today I would like to talk about NUVCs. I'm aware that I'm the last presentation before the lunchtime, so I'll try to keep it as interesting as possible for everyone. So this is what I'm going to talk about. I think when we talk about nocturnal NUVCs, which is something quite common, we do need to know what is normal before we can proceed to knowing who are the patients that have a problem. Then after that, I'll go through some important definition statistics, then go through the causes of nocturnal NUVCs, how you're going to assess the patient in a primary care setting, as well as how do you manage the patient. So this is a slide that I copied from Professor C.K. Young. He's someone who is very passionate about pediatric urodynamic. So this was a talk he was given last year in one of the conference. So he talked about different stages of bladder development. So during the fetal time, bladder mainly serves as a conduit function. It has no storage function. So kidney produces urine, pass through the bladder, and it will go out through the urethra and into the amniotic fluids. In the late fetal, early neonatal life, bladder start to have a little bit of storage functions. Then as you grow older, it becomes better in emptying. Then during childhood and adulthood, that's when we started to develop our toilet training and we become more and more mature and have a good voluntary bladder control. This is a good study back in early 2010. They compared two different groups of children, one group from Vietnam, one group from Sweden. So they're trying to demonstrate that different age of auto training would actually affect the bladder function. So in Vietnam, parents started toilet training their child much earlier. So 89% started toilet training by 6 months, and you realize that 98% of children in Vietnam actually become completely dry, diaper-free by 24 months. And when they do ultrasound on this kid, they realize that they have developed complete emptying by 9 months. This is in contrary to the children in Sweden. So Western country, Caucasian tends to start their toilet training much later than Asian. So realize that less than 5% started toilet training by 2 years old and complete emptying only at 36 months. This is the definition of nocturnal NUVCs by the ICCS. So they actually mentioned that it's involuntary wetting at night while asleep and in children aged 5 or more. I think this age is actually quite arbitrary. It really depending on when we started toilet training. But I think when they set the age of 5 years old, they're trying to make it more applicable worldwide. But you realize that if the parents started toilet training much early, and the thing is that by 5 years old, even before 5 years old, if the kids are not dry, then parents tend to be very anxious. However, if you have parents who started toilet training their child much later, even after 5 years old, if the kids have nocturnal enuresis, they may think that it is completely normal. So, NE can be further classified into monosymptomatic NE or non-monosymptomatic NE. So depending on whether they have other low urinary tract symptoms, maybe voiding symptoms or storage symptoms. And also further divide into primary and secondary. So primary are those children that never achieve dryness. Secondary are the ones that achieve dryness for at least 6 months. Then they get a recurrent enuresis. So this is some of the good statistics. This study is from China. They surveyed over 10,000 children, and we can see that on the left side, on the y-axis is percentage of nocturnal enuresis, and the x-axis is actually the age group. So with age, as the age increase, the percentage of nocturnal enuresis tend to decrease, but you can see that the line never actually go flat. So means that even into adulthood, there are still a small proportion of patients who still have nocturnal enuresis. This is a data that is a little bit closer to home. It's by Prof. Kanahe from UKM, and it was back in early 20. So she surveyed over 2,000 school kids, and as you can see here, the left-hand corner is actually for primary nocturnal enuresis, right side is for secondary nocturnal enuresis. And nocturnal enuresis seems to decrease with age. So at 7 years old, there were 9% of people who still have NE, but by 12 years old, the percentage dropped down to 2.1. In contrary, if you look at secondary nocturnal enuresis, the percentage seems to maintain regardless what age that is. So secondary nocturnal enuresis, number one is that it tends to have more anatomical or psychological causes, and also there tends to be a bit more resilient to treatment and doesn't tend to resolve with time spontaneously. So why is nocturnal enuresis so important? If you look at it, most of the paper would have quote you and say that there's an annual spontaneous remission rate of 15% a year. But having to say so, it also means that not all the children will grow out of the condition. And it may be a manifestation of something more severe. And on top of it, children who have nocturnal enuresis tends to have poorer self-esteem, they avoid social activity, parents are stressed as well because they don't get a good night's sleep. Every night they are busy changing either the diaper, either the bed sheet. And contrary to most of the belief, this group of children, they don't sleep well. Because they don't sleep well, they get nocturnal enuresis. And nocturnal enuresis would affect their sleep as well. So with the chronically disturbed sleep, it can affect their daytime behavior as well as their executive function, school performance. So now focusing on monosymptomatic nocturnal enuresis, there are three main causes of MNE. Number one is the bladder may be smaller. Two, if their nighttime urine production is higher. And number three, they may have failure to wake up in response to a full bladder, so arousal issues. Of course, there are also much more other causes. This list by no means is the end of the list. But you realize that it could be UTI, overactive bladder, detrussospindle dyssynergia or dysfunctional voiding, genetic problem. Anything that affects the brain and the nerve can give rise to nocturnal enuresis. So maybe ADHD, developmental delay, psychosomatic disorder, any spinal cord disorder. On top of it, sleep apnea, overhydration, and constipation. So this is actually a guideline by Taiwan Urological Association. The main reason why I quote this guideline is just that it is quite easy to use. They have a very good diagram and flow chart to guide you step by step what are the things to do. So if you look at this, for children who are more than 5 years old who wet the bed, Number one is that we should start with an essential assessment, including history taking, urinalysis, and voiding diary, and also limited physical examination. I'll go through this in a bit later. Now, after that, you need to determine patient is monosymptomatic nocturial enuresis or non-monosymptomatic nocturial enuresis. Means that if there are other lower urinary tract symptoms, they are the non-monosymptomatic nocturial enuresis, this group of patient, you should either refer to pediatric or by urology. But if they are monosymptomatic nocturial enuresis, you can start with some basic lifestyle advice. If it doesn't respond, then if facility are available, you can do some optional assessment like ultrasound, post-op residual urine, and uroflowmetry. So looking through this flowchart in detail, in the history, apart from asking the parents how many times the kid actually wet their bed, how often, what their fluid intake like, I think it is important to spot the red flag symptoms. These are the ones that highlight that the patient may have an underlying pathological causes that causes a nocturial enuresis. So general question, we need to ask about weight loss, growth retardation, excessive thirst, and polydipsia. So this may point to type 1 diabetes, heavy snoring, sleep apnea, or secondary enuresis, which tends to be more pathological, and also behavioral issues. May it be because of some psychosomatic disorder or neurological developmental delay that causes the NE, or NE causes secondary behavioral issues. These are the important general symptoms to know. Of course, there are also specific lower urinary tract symptoms that you need to ask, including daytime urinary incontinence, urinary frequency 8 or more times per day, urgency, infrequent voiding less than 3 times per day, holding maneuver, hesitancy, interrupted urine stream. If the children have this group of specific symptoms, they fall into non-monosymptomatic nocturial enuresis, and it should be managed by specialist center. Moving on to it, we need to ask about bowel movement. Bladder and bowel, they are next to each other. When the bladder, when the rectal is distended, it can compress the bladder neck and trigone and leads to incomplete emptying, detrusal overactivity. At the same time, they share a similar innervation. So if you don't empty your bowel well, you don't empty your bladder well. So to know whether the child has a functional constipation, the easiest way is to use the Rome 4 functional constipation criteria. It is easily accessible online. So it includes some of the questions plus a Bristol stool chart, which is the one on the right hand side. So the stool consistency, you should aim for type 3 and type 4. Anything 1, 2 or 5, 6, 7 are not good. And if they do have functional constipation, you need to treat the functional constipation first. Then after that is a physical examination. So you can actually assess the child's general health. Perhaps you can weigh them, measure their height, plot them into a growth chart. Then after that, it is important to do a quick neurological examination and also check for sign of spina bifida. Because if there is, then the NE may be part of manifestation for a neurogenic bladder. After that, it is important to get the parents to do a 2-day bladder diary. I know it is quite tedious, but it's one of those tests that if the parents are committed to it, it can give us a lot of information. Then this is a sample of bladder diary. So as you can see, there's a column for time, how much they drink, how much they pee, and certain remark, maybe whether they wet their pants, or there are some special circumstances, something that happened at that point. So a good bladder diary can give us all the information that are listed here. So it lets us know that how much a child is drinking, how frequent they are drinking and how frequent they are voiding, what are their voided volume, so usually how much the bladder can hold up to, 24 hours urine output, what is the nocturial urine output, so we can calculate whether the child had nocturial polyuria, any daytime incontinence, and also the severity of bedwetting. So this is an example of a bladder diary. If you can see, this column is a amount they drink. The second column is how much the kid actually avoid. Third is whether they have any urge. Fourth is whether there's any leak. So this is a bladder diary of a 12-year-old boy. So he has nocturnal enuresis almost every single night associated with frequency and constipation. So if you can see, the child actually sleep around 10 o'clock at night. So the green color arrows, the blue color arrow shows that those are the fluid intake just before the child goes to bed. Then the red color one over here is that after the child is asleep, woke up, decided to drink some more before going back to sleep again. And the yellow one are the maximum bladder capacity. This shows that how much the bladder actually able to hold before the child needed to walk. So as you can see, a 12-year-old boy, the estimated capacity is 360. So the child can hold up to 300 cc, 450, 550. So bladder capacity wise is perfectly normal. In fact, the child was having bladder over distension at night from all the fluids that he takes before he sleeps. And overall, you can see that the child had quite a high urine output. So we usually calculate the needed urine output is about 30 to 40 mL per kg per day. Sometimes it's difficult to judge a fluid intake because we will sweat, we exercise, weather is hot, we have a lot of insensible loss. So to know whether someone overdrink or underdrink, sometimes it's better to look at the urine output. So you can see this child had quite a high urine output of 1,008 to 2,000 a day. So just my simple fluid restriction before sleep without any medical therapy, we managed to reduce the wet night to 1 every 7 days. Another investigation you can do is uroflowmetry post-op residual, but uroflowmetry may be a bit difficult to assess too in primary care setting. But a good uroflowmetry can tell us how fast the kids are peeing, what are the voided volume, the flow time, and what are the pattern. But perhaps if you have ultrasound in your setting, you could at least do a post-op residual. Then you know that whether the kid's able to empty the bladder well. If they can't, then it may signify that there may be an underlying lower tract dysfunction. So these are some of the uroflow you can get. Basically, the bell and tower shape are the good one. So telling you that unlikely that the child had lower tract dysfunction. Plateau, staccato, interrupted, especially if repeated uroflowmetry shows similar pattern, then patient may have an underlying lower tract disorder. We may need to assess the child or even to do a urodynamic for this child. So if you are able to measure post-op residual urine, then these are the normal PVR for children. So as you can see, there's a transition. At 4 to 6 years old is about more than 30 mL. 7 to 12 is more than 20. 12 to 14 is around 30. 15 to 18 is around 30. So these are just a general guide. So if any volume actually beyond that, then the PVR is high, then we need further investigation. So these are some of the lifestyle advice that you can give the children. Number one is that they should limit the fluid intake in the evening. Avoid any caffeinated beverages, including the Coke, Pepsi, coffee, even things like Red Bull. And then they also should walk at regular interval during the day and before sleep. If there's constipation need to be treated. So being my high fiber diet, higher daytime fluid intakes, or even with some things like recluse, Dulcolax, Enema. And we should always reward dry nights. So sometimes it's good to get them to keep a diary. Every time they are dry, they put a tiny little sticker. Even though it's just a sticker, they realize that there's a positive reinforcement. And the thing is that it tends to help out with the process. And also to give the child emotional support and reassurance. In terms of management, there are 2 ways we can go. First is that you can start an enuresis alarm. 2, you can start medication, or you can use it concurrently. So for medication, there are a few main group of medication that we can use. Desmopressin is the most commonly used. Currently, we only have one desmopressin in the market in Malaysia, which is Minirate. They come in the sublingual preparation. You can start with 1 tablet and maximum can go up to 4 tablets. Oxybutynin is an anticholinergic. We give it particularly to the patient who have actually a small maximum voided volume. Mirabrepla is a beta-3 agonist. It is quite useful, but unfortunately Malaysia yet to approve for children less than 12 years old, although I sometimes do use it off-label. And then the last is imipramine. It's a tricyclic antidepressant. It is quite good for nocturnal enuresis, but it's one of those medications that parents has to be the one that give the kid. It can actually affect the heart rate and prolong the QR, so it has to be supervised intake. So if medication doesn't work, then you can shift to alarm. If alarm doesn't work, you can shift back vice versa. But of course, if with all the intervention, more than 3 months, there's no improvement, then the thing is that the patient need to be evaluated by a specialist. And if it's effective, then you can actually step up the maximum dose and get the maximum effect. Once the kids are completely dry, then you should go for structural withdrawal rather than abrupt disruption of drugs. So means that, for example, if this kid were originally on 4 tablets of desmopressin to achieve dryness, then you need to taper it at once every 2 months. You drop 1 tablet, every 2 months you drop 1 tablet. Studies have shown that structural withdrawal will prevent recurrence. If you abruptly withdraw all the drug, the recurrent rate are much higher. So just to go through the individual treatment. So desmopressin, as I mentioned before, is 1 to 4 tablets. It should be taken 1 hour before bed. And we should avoid fluid intake 1 hour before until 5 hours after administration. Because desmopressin actually is an antidiuretic, it asks the body to hold out the fluids. If the kids on top of it been drinking water on top of it, you may get hyponatremia. This side effect is more common in adults. Somehow in children we rarely see it, but it still can happen. So it is important to pre-warn the parents. Oxybutynin, the dose is 2.5 to 5 milligram. It should start an hour before bedtime. But it is important to tell the parents that the effect doesn't occur immediately. It do take time. The maximum effect can reach by about 1 to 2 months time. But the major side effect of all this anticholinergic is that it affects the bowel movement. It can lead to constipation, dry mouth. So sometimes the kid may tend to drink more, and the constipation may affect the lower tract function even more. So it is important to address that issue as well. There are other anticholinergic, but unfortunately they are not approved. For pediatric use in Malaysia yet. One more, that's metronome, but I think that they are also having some supply issue in Malaysia at the moment. Enuresis alarm, it is very useful. Nowadays it's just so convenient. It's like a tiny little sticker that you can put on the underwear. Once the underwear is wet, the alarm just ring like crazy. It can ring on your handphone and ring on the alarm itself, so wake the whole entire family up. And the idea is that it's just trying to conditioning so that the child roughly know when they're supposed to wake up. It should only be used in a motivated and supportive family, because once you bring, everybody wakes up, especially if the kids is sharing room with other siblings, may be quite difficult. Lastly, once you started any treatment, you should monitor. So this is actually this is a real diary of a kid. If you can see, this is date, day, bit wetting, bowel motion, and medication in each of the line. So every day the kid is dry, the kid put a sticker. So you can see all the sticker day are the smiley, are the happy day, so dry day. Whereas once a week, there are a couple of days that the kids are wet. So if you see this, there's a consistent trend. It's always occur on the weekend. So upon further questioning, the child actually sleep for about 12 hours on the weekend. Desmopressin only work for 8 hours. So despite the desmopressin, because the child sleep for 12 hours, the child still leak. So a simple resolution would be to wake the child up early in the morning, pee, then after that sleep again. So this is my last slide, which is summary. I'm pretty sure everyone are quite happy that this is the last slide. I'll just go through some few important things. So number 1, the definition of nocturnal enuresis is an involuntary wetting at night while asleep in children 5 years or more. The assessment is history, physical examination, urinalysis, and bladder diary. In the history, it is important to focus on those red flag symptoms. If there are red flag symptoms, you should refer to either pediatric or either refer to urology. If there are no red flag symptoms, it's a pure monosymptomatic nocturnal enuresis, you have to start with some simple behavioral therapy and then support and reassure the parents. If the behavioral therapy doesn't work, then you can start with either pharmacotherapy or enuresis. Pharmacotherapy, the first line is desmopressin, 1 tablet 1 hour before sleep, fluid restrict for the next 8 hours. It can go up to maximum 4 tablets. If desmopressin doesn't work, you can start with anticholinergic. If it doesn't work, then you can switch to enuresis alarm or vice versa. But if with all the medication or alarm, there's no improvement by 3 months, then you should refer to specialists. But if we make more improvement, then you can keep monitoring. Try to keep an enuresis diary, reward the dry night so that you can see the improvement. Once the child is completely dry, structural withdrawal of medication rather than up-drop withdrawal. That is all for my presentation. Thank you so much for listening. Hopefully you guys have a fruitful evening. Thank you.
All right, thank you, Dr. Lim, for the talk. Hello, Dr. Lim.
Hi, thank you so much for having me.
No worries. So it's very interesting talk, very details. I hope the participant found it useful. I found it useful myself as well. So it goes to the question. First question is, what role does bladder capacity play in bedwetting and can it be improved?
Okay, so this is a very interesting question. I think before my fellowship, I used to believe that bladder capacity is something that it will improve in time because bladder is supposed to grow with age. But we do realize that we actually looked through 200 plus data of those bladder diary of children before and after treatment. We realized that actually bladder capacity didn't change much though. So I have a feeling that it's actually more towards the lifestyles, the maturation in terms of the brain control over the bladder, rather than the actual change of bladder capacity. But whether for some of the patient it makes a bit of difference, it's a bit hard to tell.
Understood. So next question, are there any specific exercise or techniques can help strengthen the child's pelvic muscles to control over their bladder?
This is something that we have to be quite careful. If this is a pure monosymptomatic enuresis, means that they have no other symptoms, then all the Kegel exercises that adults use to strengthen the pelvic floor are useful. But if they have other symptoms, then it is not safe to actually go for pelvic floor exercise. Because some of these children actually have things like dysfunctional voiding, which their pelvic floor is already non-coordinated, means that they contract at the time you're wanted to avoid and then they relax at the time they're not supposed to be. If you actually do pelvic floor exercises in this group of patients, you may actually worsen their dysfunctional voiding. So it's only suitable for kids that is pure nocturia enuresis and nothing else.
So next question, is there any genetic link to bedwetting? Does it mean that the other family member has the same issue as the children, so the children might have it?
Yeah, so parents who actually have nocturia enuresis, children tend to have higher risk of getting it. But of course, there are a lot of other factors that influence it though.
I see. Okay. And the last question that we have here, should we wake our children up during the night to use the bathroom, or is it better to just let them sleep through the night?
This is always something that parents would like to ask. Our aim at the end of the day is not only for the kids to have a good night's sleep, it's also for the parents to have a good night's sleep. Intentionally waking up the kid means that the parents also have to wake up. So I think for the start, while you're still trying on the lifestyle adjustment, you're trying on the medication, perhaps that will be a temporary solution. But once I think the medication kick in, then in terms of long run wise, we shouldn't, just so that everyone will have a proper sleep. Because I think contrary to elder belief, this group of children, they don't sleep well. It's not like they can't wake up, they don't feel the bladder, that's why they actually pee on their plate. In order to pee,
the brain actually need to wake up from the REM sleep, means that they need to actually have the light sleep in order for you to pee. So if on top of their disturbed sleep, you wake them up to pee on top of it, they actually have an even worse sleep cycle. So long-term wise, it's not good in terms of cognition, in terms of behavioral, in terms of mood as well.
I think that would be the last question. Thank you, Dr. Lim, for the answers for all the questions. And thank you again for being one of our invited speakers. It will be great honor to have you on board.
Thank you.
All right, so I'll pass the floor to Dr. Jeffrey. Thank you, everybody.
All right, thank you, Dr. Shuhada, for the moderating. Ladies and gentlemen, esteemed speakers and cherished participants, as we draw the curtains on the UMC Urological webinar, I stand before you with a heart full of gratitude throughout the remarkable event. Over the course of our time together, we have delved deep into the world of urology and dismantling myth and uncovering truth. And the expertise of our speakers has definitely illuminated our understanding in this urology. I really want to extend my appreciation to each speaker who share their insights, experience, and research, and to our participants, your active engagement, your thoughtful questions, and the thirst for knowledge is the driving force behind the success of this webinar. I would like to express my gratitude to my organizing team who work tirelessly behind the scenes to ensure the seamless flow of this event. As we part today, remember that the quest for knowledge never truly ends. Thank you once again for being a part of us in this incredible journey. Stay curious, stay informed, and keep seeking the truth. Until we meet again, take care and be well. Thank you so much, everybody.